Hello.
Ma'am, you're not audible, ma'am. We are not able to hear you, ma'am.
Good morning, everyone. Nitya,
Yes, ma'am. Audible.
am I audible, ma'am?
Yes, ma'am. You're audible, ma'am.
So, good morning, everyone. Sorry for the delay. 1 minute, just an echo. You off it. Yeah, is it clear now? Is there an echo? Take it off.
Hello.
Sorry, sir. There's a disturbance. Good morning, sir.
No problem. No problem. Good morning. Morning. Are you able to hear me?
Yes, sir. You're audible, sir.
Yeah. Very good. Very good. So we'll just wait for some more time, no?
No, sir. We can start now. Actually, sorry for the delay. There was some.
Okay. No problem. We are ready to start now.
Yes, sir. Yes, sir. So, good morning, everyone. It's a great pleasure to have all of you here. I thank everyone who's present with us today. And I'll just make it very short because I should be thanking generously our chairman, Lion Dr. K.S. Rangaswamy, and our vice chairman, Mr. R. Srinivasan, our principal, Dr. Sharat Ashokan, for all the support, and also the entire team who are here with us today. And without much delay, because of all this thing, let's just get directly into the scientific sessions. I now welcome Dr. Tamil Chelvi of our department to introduce our first speaker, Dr. Arun.
Start now. I would like to introduce Dr. K.V. Arun, who has completed his BDS and MDS from Government College, Chennai. Having more than 25 years of experience in parodontology and implantology, he is currently the professor and in Ragas Dental College and Hospital, and he has lectured and conducted several surgical demonstrations and hands-on workshops at national level for various aspects of periodontal surgery and implantology. I'd like to introduce you, sir. Thank you, sir.
Thank you. Shall we start?
Yes, sir. Yes, sir.
Yeah, you just get me a minute's time. I'll just get the thing ready.
Ma'am,
So
photograph,
I
ma'am.
think you have to allow me to share the meeting. The slideshow,
Sir,
no?
we
I
have
think
made
you
you
people
the
have.
uh,
Host has to allow
sir, we have
more.
made you the co-host, sir. So I think you'll be able to do it, sir. Can you
No,
please
it
try
is telling me that the host has to allow you. Only host
Okay,
can
sir.
share this meeting, it is saying.
Okay, sir. I'll make you the host now, sir.
Yeah.
Meanwhile, I request all the participants to please switch on your videos so we can take a picture. I think if everyone can switch on your videos.
Huh? You join.
Yeah. Hello. Hello. Hello.
Yes, sir.
Yeah.
Yes,
Are
sir.
you able to
The
hear
screen
me?
is visible, sir.
Yeah. Yeah. Screen is visible. You're able to hear me. No problem, isn't it?
Yes, sir.
Yes, sir. All good, sir.
So, am I good to go?
Yes, sir. Yes, sir. Sure, sir.
Right. Okay. So, in that case, without any further ado, for all those who have logged in and are actually listening to the lecture, a very good morning to all of you. I think your state at this point of time is somewhat similar to what the periodontal defect will feel. There is an osseous defect. Some treatment has been done. It is wondering what will happen now. Similarly, you people have spent your valuable time away from Facebook, Snapchat, Insta, and whatnot. And you're sitting here and wondering whether anything useful will come out of this lecture. Isn't it? For those of you who are smart enough to just log in and not listening to the lecture at all, you're probably not going to miss anything. Isn't it? Most of the time, what the periodontal defect does is somewhat similar to what you people are doing at this point. It is hoping that the right cell will come and spatio-temporally arrange itself so that all the tissues that are important for regeneration, that is the cementum, ligament, and alveolar bone will form. But what happens half the time, it is only ligament. Similarly, you people are probably thinking that this is going to be of some use to you one way or the other. But let me start off by saying, this is not an exam point of view lecture. So don't quote anything that I am saying today for the exam, nor am I going to say things which will make you earn a lakh of rupees in a month viewing Perio. Okay, so this is neither monetary nor for an exam point of view. I am just giving you some ideas of where we are standing today with regeneration, because regeneration is something that we are all familiar with and we have been dealing with for years and years and years, isn't it? So even when I was doing my PG, although that looks as if it is sometime in 2000 years before, actually it is only 30 years. Even at that time, Melcher, Nyman, Karing, Gottlow, Linde, they have all come out with their literature. So the concepts of bone grafts and GTR was already established then. Okay? But at that time, we didn't have this tissue engineering principle yet. So since Vacanty and Langer brought out all these things, we know that cells, scaffolds, and signals in a vascularized area is what brings about periodontal regeneration, isn't it? During our times, the only cells we were thinking about is they are the undifferentiated mesenchymal cells from the periodontal ligament, as we used to call them. And we used to talk about osteoblasts and pre-osteoblasts, which will probably get induced with bone inductive factors and form bone. Those were the only cells that we knew at that time. Today, that is not the state anymore. We are talking about stem cells. We are talking about stem cells from different origin in the teeth. And we are thinking that probably it is the periodontal ligament stem cells that are best suited for regeneration. We also know that it is the endogenous stem cell that can sometimes be stimulated with growth factors, which can again help regeneration grow faster. We also know that we are also talking about allogenous stem cells. We are talking about induced pluripotent stem cells. We are talking about even cell-free cell atmosphere. What is that? When you're talking about a cell-free approach, what we are saying is you can use the conditioned medium in which the cells are growing, or you can use the extracellular vesicles, or what are called as the exosomes from the cell for regenerative therapy. So this is where we are in terms of cell. Okay, that is PDL stem cells, allogenous stem cells, induced pluripotent stem cells. Okay, also cell-free techniques like the conditioned media and the exosomes. Okay. And in our days, in terms of scaffolds, we only had collagen membranes or PTFE membranes. Okay, today that's not the state. We're talking about biphasic scaffolds. We're talking about multiphasic scaffolds. We're talking about 3D printing. We're talking about bioprinted scaffolds in which cells are already impregnated. CAD-CAM technologies, whatnot. We didn't have all this then, right? Again, from a signal point of view, we knew that there was DFDBA, but there was no recombinant growth factor technology then. Today we have many. If I have to enumerate a few, we have BMP, we have TGF-beta, we have TDGF, we have FGF, growth and differentiation factor 5, GDF, we have teriparatide, that whatnot. Right? All these were not available to us then. Now, with all this, one thing hasn't changed. Even during our times, the end point of regenerative literature used to be that histological evidence of acellular extrinsic fiber cementum forming with perpendicularly oriented periodontal ligament fibers and alveolar bone, that evidence was sometimes lacking. It was not predictable. It was not predictable then. It is not predictable now. This, unfortunately, has not changed. What does this actually mean in terms of literature? And what are the current insights that we have to this? What I am going to talk about today is purely from a clinical perspective. With this literature and with the knowledge that even though these many advancements have been made, we are still saying predictable histological regeneration evidence, that is formation of DAEFC, perpendicularly oriented periodontal ligament fibers, which actually form Sharpey's fibers and alveolar bone. If that is not predictable, what does it mean in terms of periodontal therapy? Do we do it? Do we do regenerative therapy? Do we not do regenerative therapy? Where are we today? This is all I'm going to discuss on today. Right? To give you one small perspective on regeneration, we are also thinking these days about evolution of the periodontium itself. Now we know that lower animals didn't have the proper thecodont assembly, as it is called. Thecodont is cementum, periodontal ligament, and alveolar bone. All three together form what we call as the thecodont, unlike the lower animals, which only have the acrodont attachment. Okay, now the reason why evolution of the periodontium is thought to be important is there is a saying that evo leads to devo. That means if we know what evolution is, we will find out what development of the periodontium is. And if we know what controls the development, we know that that can lead to insights into how regenerative therapy can work best. Okay, so evo to devo, evolution to development, development to regeneration. This is what is being thought about. Now, I will refer you to a couple of articles, one by LeBlanc, another by Ripamonti, who have tried to trace how the periodontium has evolved from the lower animals to man, starting from Drosophila to man. Okay, there are some interesting things that they have said, that unlike what we used to think at the time when we were studying PG, the prevailing theory today, as far as Fisher and Judy and people are concerned, is that teeth seems to form first. Only then the jaw has formed. So there are some later forms of fishes which actually have teeth-like structures, but still don't have the jawbone. Okay, so teeth formed first, then we had the jawbone. And obviously cementum formed first. and only then the other structures formed. So there are, in the dinosaur family, some extinct fossils have shown evidence that cementum is there without a periodontal ligament. Okay, so which means cementum formed first, but in those cases, not always did the periodontal ligament form, but we had the alveolar bone, right? Now, why all these things I'm saying now is the Ripamonti suggests that the genes that have led to formation of cementum and periodontal ligament, they are conserved from Drosophila to man. It is the same set of genes. It's not a different gene pool assembly completely. The only difference is they were playing a different role in Drosophila. They are playing a different role here. So the problem here is what they are suggesting is it is not just that cementum has to form. We all know regeneration means cementum has to form first. What they are saying is it is not just that cementum has to form. It has to form in the manner in which we see it today. It has to stop forming, and an unmineralized tissue has to then form, which will become the periodontal ligament, and only then the alveolar bone forms. Okay, it's not the other way around. It's not that PDL has to form first, and then you have to have a matrix which is unmineralized, which has to become cementum and then alveolar bone. Evolutionarily, they are suggesting that the cementum has to form first. Then you have to have mechanisms whereby an unmineralized tissue will form, usually by inhibition of mineralization. Now, if we were seeing each other face to face, maybe I would have dared talk a little about the molecular mechanism, which they seem to suggest is dependent on TGF-beta3 Wnt signaling, which requires receptors called the LRP3 and the frizzle receptor. Now, on a virtual lecture like this, I dare not talk about molecular assemblies anymore. Suffice it to say that what they think is TGF-beta acts on an ostrich gene, which is a gene that is important for mineralization of cementum. All right, now to give an insight into regeneration, the same Ripamonti has incorporated TGF-beta into matrigel and worked on osseous defects in baboons and showed that cementum formation seems to occur well. So what they are showing is you had cementum with large trabeculae, and that seemed to help in formation of a periodontal ligament-like structure. But unfortunately, proper Sharpies fibers didn't seem to form yet. Okay. So cut back to what I was saying initially, 25 years, 30 years or 40 years of research, what it has shown is we seem to sporadically get cementum back. We seem to sporadically get periodontal ligament, even though it is not perpendicularly oriented. Alveolar bone seems to regenerate faster. There are many, many studies that have shown that. But these two, the histological evidence is still lacking. So what does it actually mean? Should we do periodontal therapy at all for vertical defects? Should we do periodontal therapy at all for furcations? Is it that these things don't work at all and we can leave it alone and say, look, this will not work. Let us think of something else. This is the only thing I'm going to talk about from now on. Okay, again, I'm saying, don't quote me. This is just an insight into what is happening currently in a clinical setting with these defects. All right, so we go back to the basics. What are the goals of periodontal therapy? Of course, we know these two goals. First thing is to arrest disease progression, and then reconstitution of the lost attachment apparatus, which is, of course, regeneration. I don't need to explain this in detail because I think you are all familiar with this. The only thing is, now we have goals. Now imagine you people have joined PG course. There is a goal for you also, isn't it? There are some things that you must know. There are some things that are desirable to know. For example, you may be thinking that I must know how to place an implant and how to make money out of it after I have finished my PG course. So that is something that you may think is a must know. On the other hand, you may think it is desirable for me to be able to understand what the process of osseointegration is. Even if I don't know the molecular mechanisms well, so long as I am able to clinically place implants well, it should be okay for me. You may think like that. Okay, it is a must know versus desirable to know. Similarly, these goals in periodontal therapy, how much of it is actually a must-achieve goal. Now, arresting disease progression, you have to achieve. The reason why you have to achieve this goal is, if you don't arrest disease progression, we have sufficient evidence from Wang, from 70s articles which have shown that there seems to be progressive loss if the inflammatory phase is not arrested. So you will lose more attachment apparatus, you will lose more alveolar bone, you will finally end up losing tooth. So disease progression has to be arrested. It is a goal that must be achieved. However, the second one, reconstitution, is it a must to achieve goal? Okay, now nobody is saying that we don't want reconstitution. We want cementum to come back, we want PDL to come back, we want alveolar bone to come back. There is no doubt over it. But should there be a clinical setting where clinical parameters have improved, disease progression is arrested, does it matter if histological evidence is not there? Does it matter if cementum, perpendicularly oriented periodontal ligament fibers and alveolar bone doesn't form back? Okay, now to take a step back, we know that there are umpteen studies starting from Roslin, Ross Whitaker and whatnot, who have shown 18, 20 years of tooth doing well with simple open flap debridement, where all you have is a long junctional epithelium. Isn't it? The principle of getting back these tissue structures is because people feel that if you don't have these structures, the attachment is not as strong as that you will get with epithelium alone. But on the other hand, we have literature which has shown that with epithelium alone, teeth seems to survive and do well for years and years and years. Right? Cut to another set of literature. We know that if you have 50% of the periodontium left behind, okay, the tooth may be considered fit for orthodontic treatment. It may be considered to be a fit abutment. So what does that mean? For proper survival, I'm not just talking about a tooth being in place. For a tooth to be in a functional state, 50% of the periodontium seems to be somewhat enough. All right. So if in case you have a vertical defect, but you have more than 60-70% of the periodontium intact overall, does it matter if regeneration doesn't occur? Is it not enough if the probing depth has gone down? Is it not enough that disease progression is not there? Right, I will show you a couple of pictures now. These are standard cases that we come with. Now you can see the picture on the left. There is, of course, a large furcation involvement. Right. Now, if you take a close look at this tooth, yes, there is an endoperioral lesion. All that. Don't worry about all that now. What is important here is you will see the mesial and the distal roots have their full functional quota of periodontal ligament and alveolar bone. It is only the furcation space that has got involved, isn't it? Now, what is important here? The furcation problem, of course, is that it becomes difficult to maintain. Plaque maintenance becomes very difficult. There is recurrence of abscess and things like that. And you ultimately lose more tissue, isn't it? This is the problem with the furcation. Now, in our case, let us say we were to do regenerative therapy and we were able to reduce the probing depth and make this area something which the patient can actually maintain. Does it matter if regeneration does not occur here at a histological level? Okay, I'm talking at a histological level. So even if we have alveolar bone and a long junctional epithelium forming, does it matter? If the disease is otherwise stable, why should it matter? Right. On the other hand, if you look at the one on the right, you will find that the mesial root is almost completely devoid of periodontium. Now, in a case like this, regeneration or formation of cementum, alveolar bone, and the periodontal ligament inserted perpendicularly into them becomes more difficult, becomes more important, because one root is almost devoid of attachment. So if you don't get good attachment back, probably the treatment results may not be stable over a period of time, isn't it? So with these two things, we will go to why are we treating people for periodontitis at all? Right now, before we go into the complete picture about this, let us also take a look at what happens with our other specialties. Now, how do you treat caries? You make a filling, and you will find literature which has shown you how well this filling is lasting, whether there is any secondary decay, whether the color match is good, All of that, this literature will show you. They are not talking about whether dentine has come back or enamel has come back, isn't it? Now, if you take endodontic therapy, for example, what do? They remove the disease pulp, go up to the end of the root canal and fill it with gataparcha. There is no question of pulp coming back, isn't it? Although you will find that there is literature in endo about pulp regeneration, there is no literature which has said that conventional root canal fails simply because the pulp doesn't come back, right? So what we have done as periodontists is we have been scientifically accurate, but perhaps a little too accurate, as a result of which what happens is we have at a clinical level sometimes forgotten what the true endpoints of therapy are. Okay, that any therapy that you do is directed towards making the patient better, isn't it? That is a simple axiom. If the patient is, there is no point saying, no, I have regenerated 5 millimeters of bone if the patient continues to have symptoms, right? There is no point saying now cementum has come back, alveolar bone has come back, but the patient continues to have abscess, continues to have mobility, continues to have an unmaintainable pocket. There is no point in that, isn't it? Similarly, there is no point saying now the probing depth has come down, but it is just a long junctional epithelium formation from the CJ up to the apical end, and the tooth becomes mobile in another 6-8 months' time. Correct? So if you look at endpoints of therapy, there are two endpoints which have been specifically quoted by Armitage. So he calls it true endpoints and surrogate endpoints. So the true endpoints of periodontal therapy should be that after treating this patient for periodontitis, now be it horizontal bone loss, be it vertical bone loss, whatever it is, the tooth should be in a functional state, proper mastication, proper speech, proper aesthetics for 25-30 years. Then the endpoint is achieved well. But what is the problem with this? Let us say a patient walks into us, patient has periodontitis. We are saying, okay, this treatment should be done. And if he asks us what will happen with this treatment, we can't tell him, isn't it? No, I will not know what will happen for another 30 years. We will reassess after 30 years and see what it is. If your tooth is still there, it means the treatment has done well. If tooth is not there, treatment hasn't done well. You can't keep saying that, isn't it? So because these true endpoints are somewhat difficult to predict, and because it takes a long time for the true endpoints to manifest themselves, what we do instead is we use what are called as surrogate endpoints, which means those endpoints which are substituting a clinical situation, which will help the true endpoint get achieved, right? So we are all familiar with the surrogate endpoints, although the term may seem new, they are nothing new. They are all the same old things that we keep looking at: bleeding on probing, probing depth, CAL, and radiographic evidence of bone fill. Okay, now to get back to this, we know that all regenerative therapy, whether it is a current inside or whether it was what used to be done before, it seems to work well even today with only vertical defects. It works well with 3-wall defects. All this you know, so I'm not repeating this. Only with vertical defects and furcations. Predictable regeneration with horizontal bone loss is yet to be achieved. So leave that alone. So what I am saying is, what happens after these treatment procedures? Let us say you've treated somebody with a bone graft or GTR, or a combination of both this, or let us say you have used biologics, which may be autologous platelet growth, derived growth factors, it may be GEM21S, it may be infused, whatever you are using now. And you are examining this patient, let us say after 2 months, 3 months, 6 months, 1 year, and so on. And if you find that there is no bleeding on probing, we start with the first surrogate endpoint. What does it mean? Bleeding on probing, everybody is agreed on, whether it is Lang, Linde, Roseman, whoever it is, they are all agreed on the fact that bleeding on probing seems to correlate well with gingival inflammation. In fact, it is thought to be an excellent negative predictor of periodontal disease. Meaning, if there is no bleeding on probing, there is no disease, right? So you started off with a vertical defect, you started off with the furcation involvement, and you're examining this patient after some time, and you are seeing that there is no bleeding on probing. It means from a point where you had disease, now you have reached a point where there is no disease. So if this point has been achieved, the first battle is won. All right, let us be clear over this. The first battle has been won. The next thing is the probing depth. Why do we need to worry about pockets? The answer is obvious. You all know this. The deeper the pocket, the more the plaque. More the plaque, pocket deepening further occurs, isn't it? This is a vicious cycle that goes on. In today's world, we know that dysbiosis seems to be associated closely with periodontitis. Whether a pocket is an effect of dysbiosis or whether it is a cause of dysbiosis, we still don't know. But whatever it is, there seems to be a close association with dysbiotic biofilms and pocket formations. So if we don't treat pockets, we are leaving dysbiotic biofilms there and we are allowing them to start off disease progression. So if there is a pocket depth reduction, right, and we know from literature, again, many articles which have consistently shown that if we have achieved probing depth reduction to an extent where the residual probing depth is 5 millimeters or less, we know that the patient is going to be able to maintain it. Correct? So if you have done regenerative therapy, like I said, whether it is with biologics or whether it is with tissue engineering techniques or with conventional GTR, and you find that the probing depth is now only 5 millimeters or so after, say, 6 months, 1 year, 2 years, or whatever, it means the next big battle is actually won. Right? So first battle is the BPR with the BOP, the second battle is with the PD reduction, and the third one, cal gain. It does not directly tell you whether regeneration has taken place or not, because even with long junctional epithelium formation, cal gain you will get. But the clinical attachment level itself will give you a good indication of the remaining periodontium, isn't it? So if you find that there has been cal gain, and if you have started with a periodontium where more than 50% is left behind, then the war is won. So let us not forget this at all. Right? The problems as far as periodontal disease is concerned is with inflammation persisting and the pockets persisting in an area where it becomes inaccessible to the patient for plaque maintenance. Right? So if you don't have inflammation and if you don't have deep pockets that are unmaintainable, and if you have enough attachment levels left behind, it means the tooth is doing well. There is no need for us to think that clinically this is a sign of failure in any way. Right? Lastly, the radiographic evidence, that of course is a somewhat weak parameter, because the problem is we all know it is two-dimensional. We all know also that what we are seeing actually is only a radio opacity. We can't say whether it is the graft particle that is a residual graft particle or whether it is bone, and if it is bone, whether it is viable bone, all that we can't say. Isn't it? So this is as far as the surrogate endpoints go. Now, the point I'm trying to make is we have to be aware of one thing, right? There are a lot of people who are identifying furcations for all the wrong reasons. Okay, 30 years back when I started off doing my perio work, running from clinic to clinic, there were many clinicians who never bothered about the furcation. Now today, prosthodontists, oral surgeons, and endo people are identifying furcation almost as well as the perio people. And what is the reason? The endo people identify furcation and say, look, this is why the endo treatment is failing. Okay, the oral surgeons and the prostho people identify the furcation and they will say, look, furcation involvement is there. Now this tooth will not do well. So let us extract this tooth and place an implant. This is unfortunately the current situation that we are in, not only in India, outside it as well. All right, now what is the problem with this? We know from all these Wasserman-Hirschfeld studies that there are many articles that have shown that with furcation involvement too also, you can maintain teeth for 18-20 years. Right? The only problem with this regenerative approach has been that predictable cementum, that is acellular extrinsic fiber cementum, PDL and alveolar bone assembly doesn't seem to form. Okay, but look at it the other way. What is your alternative to periodontal therapy? The alternative is extract this tooth and place an implant in. Now, what happens there? Implant doesn't have cementum. Implant doesn't have periodontal ligament. All it has is an ankylosed union, isn't it? So for the tooth also, if it is a furcation involvement that can be maintained without disease progression, I'm repeating this. Now, if it is a furcation involvement that can be maintained without disease progression, meaning there is no bleeding on probing, there is no unmaintainable pocket depth, there is enough cal for the tooth to survive, and the patient is going to be able to maintain it, there is no reason to call it a failure simply because histological evidence of cementum regenerating is not there. Because the alternative is no better. Now, if we had an alternate which was far better than this, then it is okay. Okay, so this generation of people needs to focus a little more on what we call as the PROMs. Now, this has entered the periodontal literature for few years now. PROMs are patient-related outcome measures or patient-centric outcome measures. So what these people are saying is, it is not enough just to say what has happened to the pocket from the perio point of view, isn't it? We are saying probing depth has reduced. We are saying there is cal gain. We are saying there is no bleeding on probing. But what does it mean to the patient? Is the patient getting any better? Are his symptoms any better? Is he able to function properly? Okay, the reality is, although there are tons and tons of literature on lead generation, there is not so much of detail on what happens from a patient point of view. Right? Only in the recent times have they started saying that you should start reporting on the effect of therapy in terms of how many pockets have come to 5 mm or less. Okay, because the 5 mm mark is something which tell you that the patient is going to be able to maintain it. So probing depth reduction or cal gain is important only when you know how much of probing depth has reduced to less than 5. Right? So this is what they are currently saying about reporting. But unfortunately, even here, we don't know from a patient symptom point of view how much improvement is there. Then the patient has not come saying, now treat my vertical defect. He is not come saying, now treat my furcation. What the patient is worrying about is there is bleeding when he is brushing, there is hypersensitivity, there may be some dull pain, there may be some halitosis, which he wants to be get rid of. Now, has our therapy achieved that? That should be something that we should start focusing on also. Right now, again, I'm borrowing from endo people. Now, don't think I'm going on talking about other specialties. The importance today, current insight, if you were to ask me, the importance is not just to say how we can achieve complete and true regeneration, but also to see how we can keep the perio specialty alive. Right? Because we are losing out to implants in a major way. A number of periodontists themselves have started saying it is easier to place an implant than treat perio, which is for me something that is very tragic. Right? So what we have to look at is how has the oral health related quality of life improved. Now, if you look at an endodontist or an orthodontist, what they will say is the endo guy will place a few veneers in the mouth and say that not only have they changed the patient's facial aesthetics, but they have changed the person as a whole. So by placing the veneers, he has changed the patient from an underconfident, diffident person to a superhuman. Okay, orthodontists will say by aligning teeth, they have made a life-altering experience. What are we saying? We are saying, look, the probing depth has come down, correct? The cal gain is good, correct? There is no bleeding on probing, correct? There are no symptoms for the patient, correct? But still, we don't know whether cementum has come back. Okay, so this lack of regeneration from a histological point of view should be something that we discuss only among ourselves. Let us not discuss this too much with the other specialties, because the day they start saying that pulp doesn't regenerate, then we will start talking about this. They never do that, isn't it? So if you are smart, what you should be focusing on, that is the current generation of perio people, that is the PGs I'm saying now. You talk about how much patient improvement is achieved. I'm not saying falsify statements. Okay, if patient improvement is not there, say it is not there. But from a patient point of view, if there is clinical improvement, don't go on getting finicky about the histological evidence alone. Right? We will never be able to get histological evidence because for ethical reasons, we can't take no tissue, isn't it? So we can only say what has happened from a clinical point of view. Now, if that is going well, consider that this is a successful treatment. Don't go around saying this treatment is a failure. But unfortunately, I am seeing it happen far too often. People are saying that because there is no histological evidence, regeneration is a failure. It is not a failure. Right? So if you are very smart, what you should actually be saying is, what I have done with regenerative therapy is not only reduce the probing depth, not only made the patient symptom free, I have also, by taking away his halitosis that he came with, I have improved his entire social condition. I have made him psychologically better, and I have made him somebody who is more confident and now able to conquer the world. Now, if you're very smart, that is what you should be saying. Right? So this is not that I am just saying something literature that regeneration works without literature. Now, if you look at this is literature from the last 2 years. Now, some staff members in my department have taken out this literature. So you will see there are any number of studies. There are systematic reviews there are meta-analyses which have shown that regeneration works with improved probing depth results, with improved cal gains over an open flap debridement. So it is not that we'll just do an open flap debridement and still it is the same thing. What happens is when you place these bone substitutes in the right scaffold and with a membrane now, maybe later stages we'll get better materials. Even with what we have today, reasonably good material. I'm not saying you go and put some mud and then say it will become better. If we place a reasonable matrix, achieve good primary closure, probing depth reduction values are very good. So you can see here, there are results which have stretched over 18, 20 years, which have shown that they are far better when compared to an open flap debridement, isn't it? So you can see the conclusion in the bottom that regeneration provided better long-term results than flap. Okay, the important thing is, from a patient point of view, there is no tooth loss. There is less periodontitis progression, right? And importantly, it is less expensive from a re-intervention point of view. All right, so take a close look at this. For over 20 years, they have observed and they have found that no teeth has got lost, right? It is not just that no tooth has got lost, but there is lesser periodontal disease, meaning it is not just that the teeth were there, the teeth were in functional state, right? And not only that, it has been less expensive for them to maintain these teeth over these 20 years rather than extract them. Right? If we were to extract the tooth and place an implant, the cost involved there will be higher. The patient maintenance levels will not be any lesser. So in all ways, it shows that there has been considerable patient benefit with this regenerative therapy. Right? And just to make another point of this, now if in case you are thinking, what is this? All of these are Cotillinis articles. It is not that I have some bias for Cotilini or something. There are any number of systematic reviews which will show the same thing. Right? Now, if you can take this is a 10-year RCT. Now you can see these are patients who are in current classification, stage 3 or stage 4. Okay, which means severely compromised teeth, attachment levels up to or beyond the apex, right? And then they were treated both ways. So what they showed is there was 88% and 100% survival rates. Okay, that is very high, isn't it? So now what we know from this is, conclusion wise, what we know is that regeneration works well, and it is an alternative that is better than what happens when there is tooth extraction. So when we have literature that has shown this clearly, meaning clinically, if we take a look at it, the teeth seems to do well. There is a stable periodontia, meaning there is no sign clinically of disease progression. And when we are saying that the tooth is in good functional state, let us not only harp on the fact that there is no histological evidence of regeneration. Okay. Now I will come back to those initial pictures that I showed. Now, if you can look at this, you can see here, look, the probing depth is high in the picture on the left, right? And you can see the furcation involvement that is there, that is extended right down to the tooth there. Okay, let us not worry about what treatment was done, but look at the pre-operative and the post-operative results. Okay, considerable improvement in the probing depth. And this is a long time after treatment was done. Now, I'm not saying go around saying 13 mm probing depth, because 13 mm probing depth means the probe has extended right down to the alveolar canal. Obviously, it hasn't happened. So don't go around guessing things. I'm not saying falsify clinical data or make unrealistic claims. All I'm saying is make good clinical examination, get your data right. And if you have probing depths that have exceeded 8-10 millimeters pre-operatively and got them down to 5 millimeters post-operatively, what is the reason to say this hasn't worked well? I do not see why we should look histologically before we say that this treatment has worked well. At this point, okay, currently, we should not start thinking that this is a failure in any way. Right? Again, with the vertical bone loss case, you can see here, deep pocket, X-ray has shown evidence of bone loss that seems to extend right up the apex. Now, had anybody other than a periodontist being seeing this case, definitely this tooth would have been extracted and implant placed, no doubt, okay, regardless of the fact that there seems to be some ongoing periodontal disease, and probably restored properly, right? I'm not saying no. But this patient, after treatment, is looking like this. Again, considerable improvement in probing depths. Radiographic evidence I'm not showing because it may not be really meaningful. But considerable clinical evidence as far as the bleeding on probing is concerned, as far as the probing depth reduction is concerned. There is some recession post-operatively, but with defects that are this deep, it is a compromise that we have to be willing to accept. Now, if we are worried about post-operative recession and aesthetics, there is one more thing that you have to keep in mind. In today's clinical world, if we are able to manage flaps microsurgically, if we are able to do it in a minimally invasive manner, these problems will be reduced. Right? Again, this is a Brazilian article by a guy called Cirelli. It is a free downloadable article. You can read this easily. It is an easy to read article. So he's asked this question. Now, periodontal regeneration, is it still a goal in clinical periodontology? So he started this article in an interesting way. So he's asking, should we still strive for it? Should we still think regeneration is to be attempted or not? Okay, again, he said the same thing. Whatever I'm saying now, part of it, he said it in a more diplomatic and polished manner. He's saying, yes, histological evidence may not be obtained each time, but then ethical reasons will prevent us from getting histological evidence, isn't it? So he's taken a number of articles, he's taken systematic reviews and meta-analysis together, and then discussed what happens with regenerative therapy. And he's included it the same way. Let us not think that regeneration doesn't work. It works where it is supposed to work. Where it is supposed to work, 3-wall defects, we all know, works well. Furcation grade 2, it works well. But even in the 2-wall defects and the grade 3 furcations, what he's saying is the results are technique sensitive. Okay? It may not work to our complete satisfaction, but it is not that clinical improvement is not there. So he's saying, yes, there is clinical improvement. The only thing is, it is not improved to a state where we can say that the disease has got completely eliminated. Then should we treat, shouldn't we treat? We have to take a call on this depending on what are our alternatives. Now, if we have an alternative to treatment, which is better than what we are offering, then please do so. Now, if the alternative appears worse, I don't see any reason why we shouldn't attempt treatment. Right? Yeah, so the last thing last 2 points again are important. The results are highly technique sensitive. Minimally invasive principles and papilla preservation flaps should be considered wherever possible. Now, this is something that is not just quoted in literature. It is something that I have come across in clinical practice myself, that we find that once the flap management is good, now it may be minimally invasive, it may be macro surgery, but flap management is important. Once you get good passive primary closure, which has resulted from well manipulated flaps, post-operative results are always better, right? So the basic surgical skill is important. Once that is good, regenerative procedures work better. And of course, periodontal maintenance is crucial for any therapy, and it plays a key role in long-term prognosis. Now, this again sounds something that is understood, but what happens is, in many cases, we tend to ignore this. No matter how well we've done the procedure, no matter how well the tissue has responded to what we are doing, if maintenance is not there, all is lost, isn't it? Another other side of this is not true only for periodontitis. Okay, even if you were to extract this tooth and say make a bridge or place an implant, the same lack of maintenance will affect both. Right? So this is why I was saying alternatives are not very attractive. If you were to extract the tooth and place a bridge, the same lack of maintenance will start causing problems between the pontic and the abutment, between the abutment and the natural tooth, and you are going to have ongoing periodontal disease there. The same lack of maintenance is going to affect implants, and peri-implant management is unfortunately more difficult than periodontal defect management. Right? So our alternatives are not that attractive. So if we are looking at what is the current insight, although I just gave you a very brief overlook on what we are with cells, matrix, and growth factor signaling, true regeneration as defined by formation of acellular extrinsic fiber cementum, perpendicularly oriented periodontal ligament fibers, and alveolar bone is our final goal. There is no doubt over it. We should keep continuing to do things that will make that possible. But till we reach that day, it continues to be a desirable goal. Okay, the fact that we are having clinical improvement should be enough till then. Merely because we don't have histological evidence, do not say that these procedures are not successful, because that is not what happens in reality. Okay. It is important that we keep sight of this, because unfortunately, a lot of teeth which can be otherwise periodontally managed are being extracted on the premise that regeneration doesn't seem to work well, simply because histological evidence is lacking. On this note, I thank you all. If there is any question from your side, I'll be happy to answer. Thank you. And thank the organizers for having called me. I think the second year in running. Thank you all.
Thank you, sir. Thank you, sir. Thank you for sharing your knowledge and experience with us. Your words of advice will be very useful for our PGs, sir. Thank you.
Thank you.
Sir, now can you make me the host, sir? Like,
I don't know how to do it, ma.
Okay, sir. Okay, sir. I'll reclaim the host from my side, sir. Thank you.
I'm very sorry. I'm completely computer illiterate. I have no idea what to do.
Sir, we'll wait for the participants to post their questions.
Okay.
Or maybe if they want to ask also, they can unmute themselves and ask.
Yeah.
Yes, sir. Sir, meanwhile, sir, kindly accept this certificate from us.
Thank you.
Thank you for being there for us, sir.
Thank you. Thank you. Shall I leave the meeting now?
Yes, sir. I think there are no questions because I cannot see anything in the chat box.
Okay. Thank you.
Thanks for
I'll
the
leave the
wonderful
meeting then.
sessions.
Thank you. Thank you. Thank
Yes,
you.
sir. Thank you, sir.
Thank you.
Thank you, sir. Next, I would like to welcome Dr. Anita Subbappa. She completed her UG and PG from JSS Dental College. She is pursuing her PhD in the same university. She is in the last phase of Masters in Oral Laser Application from University of Vienna. And she has also completed advanced training program in surgical implantology. Madam is a reviewer for several international journals. She is now a faculty in JSS Dental College, Mysore. We are proud to say that Madam has been a part of our team Perio in our KSR Institute of Dental Science and Research for a few years. Welcome you, ma'am.
Thank you, Doctor. I'm
ma'am.
already nostalgic thinking about my days there. Thank you so much. And I'll
Yes,
share
ma'am.
the screen.
Ma'am, I've made you a co-host, so you should be able to share screen with us, ma'am.
Just give me a minute.
Yes, ma'am, sure.
Visible?
Yes, ma'am.
Okay. So I start with my topic. Just note that Dr. Arun has been telling a lot of things on regeneration and the essentiality of retaining tooth. And as he says, peri-implantitis is a little difficult to manage as compared to periodontitis. Let's see what goes by. So we have these pictures here. We have placed the implant. But what do we see in the X-ray? We see a lot of bone loss, an angular kind of bone loss. We see bone loss around the implants. This is how it is. How do we go about managing? What are the current trends in these particular things? So let's see. Despite the high success, like a lot of us have claimed high success and survival rates of oral implants, failures definitely do occur. And implant-supported prostheses may require a substantial periodontal and prosthetic maintenance over time. So we play a vital role as periodontists in these particular aspects. Long-term success of implants depends on good implant interface or union with hard and soft tissue. So osseo integration is quite vital to us as periodontists. Peri-implant infections are implant-related conditions which are increasingly being noticed nowadays because the amount of implants being placed are also quite high. There is a significant proportion of implant failures too. The health and vitality of an osseo-integrated implant depends on the surrounding supporting tissue, which not only anchor the implant to the bone, but also have something very important and vital to us, which we call the protective seal. Now, studies have suggested that over a 5-period time, 0 to 14.4% of dental implants have demonstrated peri-implant inflammatory reactions associated with crest bone loss. I think that is the need that we know a lot about peri-implantitis. 14.4% is quite high. Now, going on as to why we need to know about peri-implantitis. It was way back in 1994, the term peri-implantitis was first introduced in the first European workshop in 1994. But since then, there are numerous changes in definitions and descriptions of the bone loss. It's just the aftermath of the implant placement or in use that has been there. Coming to the recent classification in 2017, the World Workshop on the Classification of Periodontal and Peri-implantitis Disease and Conditions, they have concluded that peri-implantitis is an inflammatory process of microbial origin that causes bone loss. In addition, several risk factors have also been proposed as potential cause to these entities. And poor plaque control is one of them. Occlusal trauma, titanium particles, they are all considered as essential risk factors. Now, I have put up this article. I think you people can go through that. That includes bleeding, suppuration on dental probing, increased PPD, and from your from your maintenance protocols. It's a strict maintenance protocol that we as periodontists must be doing. So your last visit to this visit, there could be change in the probing pocket depth, And every implant has to be included in the later definition, since inflammation is characteristic of every foreign body response. That is what they call as the FBRs. Now, the next thing is peri-implantitis as a burden of disease. In the US, they spent around 2.91 billion in 2016 with more than 8,809 million implants placed. So that gives you a plethora of studies about all these clinical scenarios, the prevalence of peri-implantitis diseases, and the proportion of peri-implantitis has raised in the last 30 years. This is from the Brazilian oral research. So what's missing here? Our most vital PDL. There is osseointegration. Just a picture to depict that. Now, what is a comparison between peri-implant mucosa with the physiologic periodontium? In peri-implant mucosa, we have the desmosomes and hemidesmosomes of epithelium and junctional epithelium are linked with contact surface, which is normal with the physiological periodontium. We don't have the anchoring system of root cementum, alveolar bone, and desmodontic fibers, that is your PDL fibers. Then subepithelially, there is more collagen fiber and less fibroblasts and vessels. Whereas in physiologic periodontium, we have more fibroblasts and vessels, parallel collagen fibers in relation to implant surface, dentogingival, dentoperiosteal, circular, and transeptal fiber orientation in physiologic periodontium. So then what happens in health and disease? So we have gingivitis, periodontitis on one side, peri-implant mucositis. That itself is a different terminology compared to peri-implantitis. I just put up the slide because I'm only going to be talking of peri-implantitis, not mucositis. When peri-implant, my mucositis is limited to the soft tissue. When the disease is limited to soft tissue, we call it the peri-implant mucositis, and we call it peri-implantitis when extended into the crested bone. Now, we have a soft tissue interface. We have the gingival fibers, which insert perpendicular to the cementum. They insert parallel to the implant and are not inserted there. Junctional epithelium is poorly adhering in our implant system, more permeable, low regenerative capacity. They have direct contact with bone. And in coming to the hard tissue, you have a rigid connection, which is the osseointegration, stressing on the fact of osseointegration. Cementum and PDL are absent here. Now, what actually are these terminologies? Peri-implant disease is the inflammatory lesion that develop in the tissues around the implants and are collectively recognized as peri-implant diseases. But peri-implantitis is a progressive and irreversible disease of the implant surrounding the hard and soft tissue and is accompanied with bone resorption. So definitely there's going to be bone resorption, decreased osseointegration, increased pocket formation, and purulence. So this is the definition of the peri-implantitis. Mucositis is bacteria-induced, reversible inflammatory process of the peri-implant soft tissue with reddening, swelling, bleeding on periodontal probing, as you can see in these pictures here, that there is reddening here, deepening of the PDL. An ailing implant, whereas, is an implant that can demonstrate radiographic bone loss with pocketing, but without inflammatory signs of mobility. Now, this could be static for around 3 to 4 months of maintenance checks. Failing implant demonstrates increased probing depth, suppuration, or bleeding when probed, and progressive bone loss. Failed implant is no longer osseointegrated or never achieved osseous integration. So you'll find many cases of failed implants too. This is the three-dimensional picture of the tissue and the titanium interrelationship that you can see here, showing an overall zone of the intact interfacial zone around the implant. I'll skip this since I have since I assumed that, but let me just tell you what osseointegration is. It's defined as a direct structural and functional connection between ordered living bone and the surface of a load-carrying implant, which is critical for implant stability and is considered prerequisite. So whenever we have placed an implant, there is a direct bone to the implant connection, and it is a prerequisite for any loading and long-term clinical success. Otherwise, like I just mentioned, we will go in for a failed implant. So the 5 key parameters of mucositis would be BOP, redness, swelling, loss of texture, and it is seemingly painless though. The term peri-implantitis was introduced a few decades ago by Levignac in 65 and Mombelli et al. In 87 to describe pathological conditions of infectious nature of tissue around the implants. It is characterized by inflammatory lesions in the peri-implant tissue and associated with loss of supporting bone. So remember, there is loss of supporting bone just like we have in periodontitis. It is around the implants. The loss of the supporting bone is quite vital because it is a difficult to treat scenario as it progresses. Peri-implantitis represents a clinical condition which includes an inflammatory lesion in the peri-implant mucosa and loss of peri-implant crestal bone. So here comes the picture of knowing peri-implant mucositis 2. I'll skip this on histopathology. Now, this is the number of implants that are sold in millions. By 2023, they hope to cross 200 million. And the burden in India, we're talking of a mathematical model in the Indian population, an estimated number of peri-implantitis would be around 1,45,543 to 2,54,700. And estimated number of failures would be 50,940 to 79,412. So that is the need for knowing the management, the essentiality or the outline of peri-implantitis, how to manage it, and how to go about it. Peri-implantitis is polymicrobial. So it could be a plethora of microorganisms like P. gingivalis, Stannarella forsythis, Treponema denticola, Prevotella intermedia, Prevotella nigrescens, Aggregatibacter. But also there has been certain studies which also say HSV1 also has been contributed. There was one study by Zitzman et al. In 2006 where quantified the incidence of the development of peri-implantitis in patients with a history of periodontitis. That is almost 6 times higher than in patients with no history of periodontal inflammation. Now, this is a study evaluating the microbiota of the peri-implant area of failing implants. So, etiopathogenesis, we have Mombelli et al., Listgarten and Van Winkle, Hoff et al. So, all of them say that it is due to a group of microorganisms. They have said FN, spirochetes, PG, actinomyces, fusobacterium. Implant loss was highly associated with P. gingivalis, according to Van Winkelhoff. And Leghorn also contributes to spirochetes. So it is a plethora of microorganisms too. Now, S. aureus also has been shown to have a high adhesion for the titanium surface and has been associated with bleeding on probing and suppuration. What are the biomechanical factors? They do not accommodate increased biomechanical stresses due to the fact that the implants move minimally, microfractures of the bone, and a reduced area of support. So whenever there is excessive biomechanical forces, there is microfractures, loss of integration. This was given by Hayden et al. And Linde et al. In 92. The role of overloading is likely to increase in 4 clinical situations: poor quality of bone, incorrect implant position or number, parafunction, precise fit. So it has been shown that inflammation is more pronounced and inflammatory process goes deeper and faster around the dental implant than around the adjacent natural tooth. But do remember that whenever you place an implant in a periodontitis case, untreated periodontitis case, it will go for a failure. So make sure periodontitis is a risk. Remember, periodontitis is a risk factor for placing implants. Coming to the pathogenesis. Just have a look at these pictures. What do you observe here? This is an implant with a denture here. You notice some deposits, isn't here? And when the flap was opened, you can see the amount of bone loss around the implants. So how do we go about treating? This was a mucoperiosteal flap that was raised. As I just mentioned, I have something here, sorry to break. Some Shreya has entered the waiting room. Should I admit? Should I be doing all this?
No, ma'am, not required, ma'am. We'll do it from our side. Thank you,
Okay.
ma'am.
Now, bacterial accumulation, I just mentioned, of Staph aureus, HSVs, PGs, your plethora of pathogens. So basically, it's due to poor oral hygiene, which is the predisposing factor on implant surface. It triggers a host-bacterial interaction. And you have mucositis and an implantitis that is onset. But the rate of destruction is higher in peri-implant tissues, according to Brandes et al. And Lang et al. Linde in 1992 has said the size of infiltrate was larger in peri-implant tissue, and inflammatory cells were also seen extending into the bone marrow spaces. So remember, it resembles osteitis. So Linde has given a beautiful article. You can go through that. Now, role of immune response, do they actually play a role? Complement activation on foreign body reaction, that is, an immune response cascade is initiated. There is macrophages, monocyte chemotaxis, and bone cells which are regulated. Macrophages M1 and M2, which are pro-inflammatory and have healing properties, are migrating to that area. Giant cells are also found on the implant surface. There is upregulation of immune response after the implant installation within the first 10 days. So what are the other factors? Titanium metal particles, occlusal overload, genetic predisposition, and excessive cement. All these contribute to the pathogenesis. Why bone loss around implants? Initial stages of healing and during later stages. Loss of facial, FBR is what I earlier mentioned. Balance, which is lost, and the exact pathogenesis is not clearly understood. They put in only a hypothetical model. So they say there is a loss of equilibrium because of cement remnants, titanium particles, complement and macrophage activation, upregulation of osteoclastic activity contributing to the bone loss. So cement remnants, titanium particles, they trigger a complement macrophage activation. There is upregulation of osteoclastic, which definitely would cause bone loss. There was a study by Albrechtsen et al. Where he says there is a late disbalance of foreign body equilibrium, FBEs, the occlusal overload or the cementum remnants or the bacteria. He contributes to all these three things. And he says the chronic inflammation accompanies foreign body response and marginal bone loss, that is MBLs. There's another study by Koka and Zam where osseoseparation, that is the failing implant, rather than peri-implantitis, which refers to a disease. So he's classified failing implants a little different from peri-implantitis. Now, what is this foreign body reaction that we are talking of? After 90 days, inflammatory cell infiltrate is quite high and extends to the bone marrow. There is greater plasma cells and lymphocytes, massive proportions of PMNLs and macrophages. Different RNAs are expressed in peri-implantitis associated with bacteria and immune response, respectively. Now, coming to the titanium particles, there is degradation of the titanium oxide layer. Of course, they get removed, but there is always a layer that is always formed. It is continuous wearing. That's because of the continuous wear, exposure to chemicals, bacteria and their products, and the presence of an acidic environment that can degrade the titanium oxide layer. So there is continuous degradation, and you find this titanium oxide layer, which would bring about your foreign body reaction, triggering the osteoclastic activity. This titanium particle may occur in any of the rehab phase, could be in the prosthetic phase, the surgical phase, or the maintenance phase. Now, coming to occlusal overload, there are lack of randomized clinical trial studies. So whatever is there are this is contradictory result. Yes.
No, ma'am, you were not audible for a short period of time. Now you're audible, ma'am. Thank you.
Heats and Manfield et al. Found no difference in marginal bone response at all. So there is a contradictory study when it comes to the occlusal overload. There is a relative lack of randomized clinical trial studies. And the contradictory studies would say that Gottfredson and Heats and Mayfield are giving contradictory studies. But occlusal overload is also contradictory. Coming to the genetic predisposition. Genes encoding CD14, rankles, microRNAs, BMPs, that is bone morphogenic proteins, fibroblast growth factors, the BRAF, the TANG, all these calcitonin receptor haptoglobin, all these contribute relatively to the pathogenesis part. Now, Hamdi and Ibrahim has said in IL-1 alpha 889, IL-1 beta plus 3954 allele2 genotypes higher risk for greater implant tissue destruction. So what are the risk indicators? History of periodontitis, like I mentioned earlier, dental plaque and poor oral hygiene, very vital to us. Smoking, alcohol, diabetes, very important. Genetic traits, I just mentioned now. I'm having some voice echoing here. Lack of keratinized implant surface characteristics or risk indicators. Now, how do we manage this? Let's have a look at this particular case. What do we observe? We observe that
Anita, I think, yeah, you can unmute and continue.
Yeah, just have a look of this particular case. A full thickness mucoperiosteal flap is raised. But what do we see around the implant? We see some amount of marginal bone loss, supporting bone loss. How do we go about managing? One is the conservative management through decontamination methods, surgical management. The surgical management would include access flap, resective therapy, regenerative therapy, biomaterials which are included, your bone grafts, your GTRs, your bone morphogenic proteins, etc. Implant removal, the last thing, remove and place additional implants, treat that area, and then place the implants. Adverse outcomes. Recession, recurrence, cost, and patient preferences are also vital to us. Now let's see. This was the clinical ITI consensus clinical recommendation in 2014. That's quite recent. The goal is the resolution of infection and prevention of recurrence. 6 steps towards that goal. 1 is pre-treatment phase. Step 2, non-surgical debridement. Step 3, reassessment. Step 4, surgical treatment. Step 5, immediate post-op care. And then we have the supportive care. Carefully assess and diagnose. Thorough assessment. Remember the risk factors. Remember that the patient needs to have adequate access to plaque control. So remember to tell him to stop his tobacco habit and make sure his diabetes is not brittle diabetes, but well-controlled diabetes. You have the glycosylated hemoglobin checked. Then poor oral hygiene, that is, you check the other areas, or when he comes back after the implant, you just check it. And you see in this picture that the patient is not maintaining oral hygiene well. Poor plaque control is very, very significant in development of peri-implantitis. Then the history of periodontitis, that means the patient is treated. The patient has been treated, and the regenerative therapies that you have contributed to for treatment of periodontitis has taken up well. But do remember, you placed an implant in the adjacent site, and the patient oral hygiene maintenance is also vital. Smoking. It has been found that cigarette smoking increases the bone loss rate around implants by 0.164 millimeters per year. Now, the studies also reported that in smokers, significantly more marginal bone loss have been seen after placement and higher peri-implantitis percentage. So go for TII center, tobacco intervention centers, have them to get the counseling done, give them alternatives to tobacco replacement, chewing gums and those kind of sorts, so that he stops the habit, he or she. Alcoholism break the prothrombin repletion and does reduce it, affect the coagulation mechanism. They contain the contents found in alcoholic beverages as a mixture of toxic alcohol, that is nitrosamines and ethanol, can cause osteoporosis as well as inhibit bone stimulation. Explain to the patient about these tobacco, about diabetes, about alcoholism, and tell them why actually we are asking them to refrain from smoking and from drinking. It has been reported that drinking more than 10 ml, 10 grams of alcohol a day causes peri-implantitis rather than smoking. But don't say that cigarette smoking is fine, alcohol is bad. No, cigarette smoking is also bad. So you can put them up to a TII center, tobacco intervention center, or alcohol centers where they can beat the habit. Coming to diabetes, we all know that ages are liberated, and we have a two-way relationship, and we also have periodontitis as a sixth complication of periodontitis. It is more common in diabetic patients, so make sure brittle diabetics, you don't attempt to place an implant at all, because they are not going to control, their diabetes is not under control, and the oral hygiene also needs to be checked, their plaque control, before you place an implant. It has been, so there is increased tendency of peri-implantitis in this group of patients, in diabetic group of patients. Now going on to the genetic traits, VEGF, it's not any veg puff, it is vascular endothelial growth factor, which may play a protective role in marginal bone loss. In case of rheumatoid arthritis, it is found that the areas of marginal bone loss around the implant were very seriously increased because of the expression of this VEGF, which is quite low. And this is the reason for the risk of peri-implantitis. So you see in this picture that VEGF is vital for osteoblastic and osteogenesis, though growth factors and oxygen and nutrients are vital. We find that lower number of VEGF is seen in rheumatoid arthritis, which is the reason for the risk of peri-implantitis. A genetic disorder characterized by interleukin-1 gene polymorphism is also suggested as a risk factor in the pathogenesis of peri-implantitis. Mutation in the interleukin gene clusters, which would also alter the interleukin-1 receptor antagonist, which would weaken the natural antagonist of interleukin-1. Consequently, the interleukin-1 can freely unfold its pro-inflammatory effect. This mutation is responsible for overproduction and decreased inhibition of interleukin-1, which will amplify and produce an even greater risk for periodontitis and implantitis. lack of keratinized mucosa, the healthy keratinized gingiva around dental implants may offer resistance to the forces of mastication. It's quite vital. So the frictional contact is prevented. The minimum width that would be there, that would be required in teeth is 2 mm. This concept has been carried over to the peri-implant zone, and the narrow zone of attached gingiva is associated with higher chance of gingival inflammation. We will not go into the details of attached gingiva and vitality of having that minimal width, but we do know that minimum width of keratinized gingiva or the attached gingiva is vital to peri-implant area also. Now going on to the implant design and surface design of an implant causes or affects the tissues around the implant. Factors such as implant abutment, platform switching concept, and surface roughness can determine the amount of bone loss. The comparison is on a standard platform implants, that there has been less bone loss in implants when the design is in platform switch. I have an article reference for this. I will put that up. So this is your platform switch where there is a groove in the implant for soft tissue formation, which helps maintain the biologic width. The biocompatibility of titanium is attributed to its surface properties. So any exposing of any rough implant surface, supposing you're decided to do maintenance therapy and you have used your SS 2R2L or 4R4L or any of Euphridy Gracie curates, you've cordled for an implantitis. There is roughening of the surface. The environment is allowing for the adhesion of the plaque, and there is surface roughness could be as much as 0.2 micrometers. In case of implant grooves with rough surface are exposed, these surface needs to be smoothened and polished to prevent plaque buildup. Now I'll skip this diagnosis because we all know that clinical is required, radiographic is required, and we also have the other instruments. So basically, how would you diagnose? Bleeding on probing, suppuration here. You can see the amount of bone loss here. Radiographic bone loss, probing pocket depth will be bigger, and the implant mobility. Once the implant mobility sets in, you know you're leading on for a failure. Step 2, non-surgical management. Non-surgical debridement focused on maximal removal of biofilm with or without antimicrobial therapy. Microbial etiology has to be removed, so the need for the anti-infective therapy. Polishing of accessible surfaces with pumice, subgingival irrigation with 0.2 chlorhexidine. You can have an irrigation device. Systemic antimicrobial therapy can also be given for 10 consecutive days. But remember your resistance chains too. So debridement and detoxification can be done using curates to remove calculus, rubber points, abrasive paste, abrasive air, Teflon, titanium brushes. You can see the pictures here. Antiseptics such as citric acid, tetracycline 5%, hydrogen peroxide 10%. Antibiotics, metronidazole can be given. If you have tried GBR, you can give onidazole and doxycycline combination. Now going on to local drug delivery, that also can be attempted in these peri-implantitis lesions. Controlled delivery devices, you can have Arrestin, you can have tetracycline fibers, you can have minocycline microspheres, you can have chlorhexidine gel, you can have chlorhexidine chips. Then you can also irradiate with a soft tissue laser. You can have ERIAG and carbon dioxide. And you can use phthalocyanine. You can do PDT for photodynamic therapy too. There was this study in Journal of Dentistry where a new controlled release material containing metro and doxy for the treatment of periodontal and peri-implant disease. So they had formulated this metro and doxycycline combination, and there was local drug delivery of chlorhexidine too. The formulation of a controlled release material containing metronidazole 20 milligram and doxycycline 10 milligram per ml was used. An in vitro evaluation of the antimicrobial properties against planktonic and biofilm species involved in periodontal and peri-implant disease. And they've concluded that the control release gel containing metro and doxy had an optimal final viscosity and mucoadhesive properties, and it is useful in the treatment of perio as well as peri-implant, where conventional therapy seems not successful. Going on to the next thing, reduction of clinical signs of peri-implant mucosal inflammation, submucosal debridement, local drug delivery of antibiotics, submucosal glycine powder, air polishing powder that is there, area glazer treatment, submucosal debridement using curettes, Teflon coated curettes, or your titanium curettes, adjunctive irrigation with chlorhexidine. Step 3 is reassessment, early reassessment of peri-implant health, normally within 1 to 2 months. Step 4 is surgical management. You have to have the access through flaps, apically positioned resective procedures, access for cleaning and decontamination, regenerative procedures, where you have access for cleaning, plus you aim at regeneration and re-osseointegration. Surgical access, when it is done, go for a full thickness mucoperiosteal flap. Resective is indicated when there is moderate to severe horizontal bone loss, 1 and 2 wall defects. Implant position is an anesthetic area. So apically displaced flap techniques and osseous resective therapy are used to correct horizontal bone loss, and moderate, that is less than 3 mm vertical kind of bone loss. Full thickness flap is reflected to access the surgical flap and to improve the follow-up maintenance. You can have a look at this picture. A full thickness flap is elevated and an apically repositioned flap is placed. Now, coming to regenerative therapy, there is a study by Shao et al. Where a bone substitute with or without the use of resorbable membrane. And there are controversial data. Some say there is reasonable regeneration, but some say there is no change. To accomplish this regeneration of this lost bone tissue and re-osseointegration, GBR and bone graft techniques have also have long been suggested. If you have a look at this picture at the bottom of this slide, you will see that a graft is placed around the bone, in the bone area of bone loss, and a membrane tube is placed. Roos and Jansacker et al. Have shown that 12-month results can be maintained for over 3 years when patient is maintaining good oral hygiene. So I repeatedly stress the fact of the significance and importance of good oral hygiene. So this is another picture of peri-implant regenerative therapy. You can see this radiograph pre to post regenerative therapy. So lost bone tissue, GBR and bone graft techniques have long been suggested, like I mentioned just now. You can see the clinical pictures. This is another clinical scenario that we can appreciate, that the bone, that the implant can survive post GBR. This is the surgical appearance of a bony crater in the first picture around an implant. There is application of a bone substitute. It could be synthetic or autograft, but here it was Alipore and Tigritin TM. This is a bony crater around the implant. You can see that application of a bone substitute bio-os has been placed, and a resorbable membrane is also placed to hold. This is another clinical scenario. You can see that there is bone loss around the implants. A full mucothickness periosteal flap is raised. Bone graft is placed around the implant area where there is bone loss. This is the GTR membrane that is placed. So now I'm putting up these experimental studies which evaluate the effect of surgical treatment and various decontamination methods for re-osseointegration of dental implants after peri-implantitis initiation. So open degranulation and mechanical debridement of the infected implant surface together with different regenerative procedure, GBR, tissue engineered scaffolds to induce osseointegration. So Shao et al. Has done it on animal models. And he has concluded that membrane with AB shows more, antibiotics shows more significant results rather than other groups. He has also used bio-os and membrane preferable for the treatment of peri-implantitis. And in another study, Shao et al. Has silk ligatures and is used air powder abrasive system. And he concludes that the simplest method, including bar soap alternative in fluoxetine and saline, should be used in the surgical treatment of peri-implantitis with AB and membrane. Now, there's another study by Shibley et al., Person et al., Senerbi et al., and Stubinger et al. They conclude that the treatment by means of photosensitization may contain significant bone fill with re-os. And re-os is better than SLA surface. We know what SLA surface is. I'll not go into the detail. Carbon dioxide laser and hydrogen peroxide had no apparent effect. And Senerbi et al. Concluded that a resonance frequency analysis technique may be used to detect the BIC. And after 4 months, the results showed significant more new bone formation in defects. BIC means bone implant contact surface. The other studies by Schwartz, Park, and Marshall and Hittet et al. Have used different decontamination method, which would be debridement, dental water jet, and floss soaked in fluoxetine, 24% UDTA, area laser, PDT, titanium burr, and titanium burr with citric acid. And they've concluded that the combination and the techniques were quite vital and could be used. Now, this is another clinical scenario. You can see that the probing depth is quite high and the radiographic bone loss around the implant. So in this particular case, a diode laser therapy was done and there was significant reduction in the edema. And we can see that there is bone fill around the implant. Ozone therapy as an adjunct has also been tried and tested. The effect of ozone as an adjunct to surgical treatment has been demonstrated to have good results. This is given in the Journal of Periodontal Implant Science. So ozone therapy can be used, which promotes hemostasis, enhances the release of growth factors, upregulates cellular antioxidant enzymes, and inhibit bacterial proliferation. I was earlier talking of the platform switching, the gap that is given for soft tissue accommodation. This is given in Quintessence International, where they show positive results and lesser instance of peri-implantitis. Now, step 5, immediate post-operative care. Anti-infective protocol should include daily chlorhexidine rinsing during the healing period until mechanical oral hygiene can be resumed. And in the absence of any evidence comparing surgical treatment with or without antibiotics or ABs, peri or post-operative systemic antibiotics are recommended in view of aggressive nature of the disease. Professional support of healing and plaque control will be needed during this phase. Supportive care, very vital and likely to be taken up for up to 3 to 6 months. And clinical monitoring is quite essential, supplemented with appropriate radiographic evaluation stage-wise. So the maintenance protocol, remove the prosthesis if you see any peri-implantitis, detoxify the platform and screw opening, curate the pocket lining, and replace restoration and apply pressure. But remember, PI, P. nigricans, Streptococcus constellus have all shown resistance at varying percentages. This I'm mentioning because I've been recommending antibiotic supplementation, both local drug delivery and systemic. The patient should be advised that the recession of peri-implant mucosa should be expected for following peri-implantitis treatment. Remember to tell them that, in particularly after surgical therapy, they should consider implant removal as a treatment option when there is mobility. So suppurative exudate, overt BOP, severely increased peri-implant probing depth, Radiographic radiolucency is extending far along the outline of the implant greater than half length. Peri-implant probing depth greater than or equal to 8 mm. Mobile, non-surgical and surgical therapy you have tried and it is ineffective. So now going to the decision tree for management of peri-implantitis. Mobility, yes. Failed implant, remove it. Don't think twice. When it is no, and you see a bone loss radiographically, failed implant, extent of bone loss is what you're going to assess. Recommend implant and redevelop the site, do the GPR, redevelop, and then replace the implants. If less than half implant fixture, check the amount of bone loss, greater than 2 millimeters, apically positioned flap with osseous resection, GBR, flap surgery, antibiotics is what is recommended. Less than or equal to 2 mm, non-surgical therapy, scaling, root planing, surface decontamination, antibiotic, local and systemic, lasers can be tried. If there is no bone loss, but there is an ailing implant and peri-implant mucositis, non-surgical treatment, scaling, root planing, antibiotics, subgingival irrigation, and antimicrobial mouth rinse should be sufficient. Now, implant maintenance was given by Lang et al. In 2003. Of course, it was modified a little later. Cumulative interceptor supportive therapy principle is to detect peri-implant infection as early as possible and to intercept the problems with appropriate therapy. The protocol relies on PPD, BOP, and radiographic evidence of bone loss. The basis of this system is a regular recall of the implant patient and repeated assessment of the following key parameters: BOP, plaque, suppuration, peri-implant pockets, and radiographic evidence. So, to evaluate and intercept the progression of peri-implant disease, Mombelli and Lang et al. Suggested a protocol. This is the CYST protocol, which is step 1, antiseptic therapy with protocol A, step 2, antibiotic therapy with protocol A and B, step 3, antibiotic therapy with protocol A, B, and C. Antibiotic therapy is step 4 with A, B, C, and D. So what is this A, B, C, and D? A protocol, PBD is less than 3 mm. Or greater than 3 mm, negative bleeding on probing, negative bone loss, only mechanical debridement is required. If it is greater than 3 mm and positive for bleeding and probing, negative bone loss, mechanical debridement and polishing is sufficient. Protocol B, 4 to 5 millimeter, positive for bleeding, negative for bone loss, antibiotic cleansing of 0.1%, and chlorhexidine plus chlorhexidine gel can be given twice a day for 3 weeks. Protocol C, greater than 5 mm PPD, bleeding on probing is positive, notable cratering less than 2 mm, systemic antibiotics is required. And protocol C is a surgical therapy warranting surgical therapy most definitely, greater than 5 mm, positive bleeding, bone loss greater than 2 mm, regenerative surgery is what is required. So this is roughly the flow chart of PPT less than 3 mm, plaque index 1, BOP negative, where you do mechanical scale and polish. PPD 4 to 5 mm, you do A plus B, where you add this chlorhexidine gel. PPD greater than 5 mm, you have no cratering, then systemic and local antibiotic therapy. Cratering is there, resective and regenerative therapies are required. So you can have A plus B plus C plus D 2. So this is a table which with different clinical methods. There is sandblasted acid surface, plasma sprayed surface, and smooth surface, where X is a yes and 0 is a no. So a rubber cup cannot be used in these particular cases. Metallic curette and rotating titanium brush can be used in SLAs. Plastic curettes is again a big no. Ultrasonic systems with metallic tips in a smooth surface, polished is what is required. Ultrasonic systems with plastic tips is a big yes for SLAs and plasma sprayed. Air polishing is a big yes for all three. Lang et al. Later changed the CIST protocol, CIST protocol, and called it the ARCUT protocol. And he gave this particular thing where Pocket depth is less than 3 mm, plaque and or bleeding or probing, mechanical cleaning, polishing, and oral hygiene instruction. Stage B, PD is 4-5 and no bone loss. You can give CHX therapy along with mechanical cleaning. Stage C, PD 5 and radiographic bone loss less than 2, mechanical cleansing, polishing, microbiological test for antibiotic susceptibility testing can also be done, local and systemic anti-infective therapy based on the antibiotic susceptibility testing. Then stage D, PD is greater than 5, radiographic bone loss is greater than or equal to 2, resective or regenerative therapy. Now I have just another 2-3 slides to finish. Patient's role is vital, so make sure your oral hygiene instructions are given. Give them interdental brushes or hand or motorized brushes. Then you can give dip brushes into dip. You can ask them to brush, dip the brush in chlorhexidine and then use it. Use a floss, tapes dipped in chlorhexidine. Check them every 3 to 4 months. Check for the efficiency of plaque control. Now, preventive measures after implant placement. All oral healthcare providers, including undergraduate students, should be trained to recognize the clinical signs of peri-implant pathology and maintain to re-establish peri-implant health. Of course, periodontists who perform the surgical resective or regenerative therapy, but undergraduate students should be able to recognize that. During SPT, an update of medical and dental history, again, where maybe the patient has become diabetic or his blood sugar levels have started to be brittle, his glycosylated hemoglobin is quite high. So an update on medical and dental history is quite vital, whether they have gone in for any adjacent areas or whether cement remnants are there, misfit prostheses in adjacent areas, implant proximity to insufficient access, all this are vital, so to reassess. So this is the article I was talking of, laser therapy for implant mucositis and peri-implantitis treatment. It was given by, it is a review article by the American Academy of Periodontology. So laser therapy can be used. In-office implant maintenance, select the instrument. Tip should not be bulky. Design should be easy. Location and tenacity of the deposit to be removed. Instrument should be disposable and to be sterilized and cost effective. So this is your implant care tips, scalers and curates, plastic, graphite and solid titanium. Plastic scaler tips around implant ball abutments, titanium scaler use around the locator abutment, and a graphite scaler used in a header bar. Air polishing, the main indication is plaque removal. 3i implant innovations, abutment glow polishing paste. They've given up this abutment glow polishing paste, so that can be used. So you have this detoxification using air polishing device with glycine powder too. Jet Fresh is from this Kawo Dental, from Hong Chang Dental Equipment. Then you have Kawo Dental and all this, where damage to the porcelain or composite material, they can create random pitting or undulating wave type of surface irregularities. And glycine air polishing, which I just mentioned, European 8 conference in London and UK, they recommended on the clinical application of air polishing for the management of peri-implant mucositis and implantitis. So they say this glycine air powder polishing is effective as the controlled treatment at mucositis and peri-implantitis areas too. Early intervention is important. Locally applied, I was talking of local drug delivery. You can even use Atridox, Perio-Chip, Dentomycin, or subgingival irrigation with peroxide, Listerine, or chlorhexidine. A plastic irrigation tip should be used. Sodium fluoride can also be used at 5,000 ppm. To conclude, peri-implantitis is a treatable disease that affects the functioning of the osseointegrated implants. Treatment of peri-implant infection aims at suppression of the gram-negative anaerobic bacteria and the establishment of the local environment and the microflora. Clinicians should make a judgment, decide on the implant designs, patient maintenance, put them under a protocol, put them under a surgical therapy whenever it is warranted. Education and motivation is quite vital because plaque control is very, very of paramount importance. With this, I thank you. I sincerely thank the chairman and the vice chairman of KSR, principal, and of course, without Esther, I don't think I would have been there. Thank you, Dr. Esther and team, for having me here.
Thank you, ma'am.
Thank you.
Thank you, ma'am, for enlightening us about the current concepts of peri-implant disease and its management. We'll wait for a couple of minutes for questions, ma'am, if they are having. Yeah, there is one question, ma'am. Ma'am, resective surgery will reduce bone support for implant. Then how can this be indicated in its treatment? Somebody has asked.
If you have a lead sort of a defect, then we have to do an osteoplasty sort of a treatment.
Okay. Ma'am, kindly accept this certificate from us. Thank you for joining us today, ma'am. It was a pleasure having you.
Thank you.
Thank you, ma'am. Now, I request Dr. Bharati to introduce our next speaker, Dr. Arpita. Bharati?
It's a great pleasure for me to introduce our speaker for the next session, Dr. Arpita ma'am, who is currently the professor and head, Department of Periodontics, Mamata Dental College, who is going to talk to us about the current concepts in periodontal medicine. She has completed her BDS from AIB Dental College and Hospital, Karnataka, and pursued her MDS from Meenakshi Amma Dental College and Hospital, Chennai, and completed her fellowship in oral implantology. She has 29 publications in various international index journals and has delivered 15 guest lectures and various live surgical demonstrations. We welcome you, ma'am.
Okay, as I'll have to, I have to see how I can share my window. I'll just a second.
Yes, ma'am.
The thing is, whether you're able to see my screen or not.
Not yet, ma'am.
Okay, then you need to guide me as to what I'm supposed to do, because
you are the co-host, so you will be able to share the screen.
Okay.
Just try it, ma'am.
Okay.
In the bottom of the screen, you will have a thing that says share screen.
So, yeah, I did that, but then I was not able to do that. That's the reason I'm asking. If you will give me a few seconds.
Yes, ma'am. Sure, ma'am. No issues.
I don't know. I mean, still not able to view the screen?
No, ma'am.
Okay. Then can we just wait? Okay. I don't know. There's something wrong here, so I'm not able to share the screen with you. Okay. No, it's the thing.
It was your video, ma'am.
Yeah, that's what. The thing is, okay, 1 second. Okay, are you able to see now?
Yes, ma'am. It's visible.
Okay.
Yes.
Sorry for the delay.
No issues, ma'am. No.
Okay then. A very good morning to all of you who are listening. The topic which Dr. Esther gave me was something which really was something I thought maybe I don't know how much I'll be able to do justice, but this is a topic which I got and I really loved making the presentation while doing that. So the topic I have today is current concepts of periodontal medicine. And if you see the contents of this, you will know that this is a huge topic to discuss in an hour. So what I would do basically is discuss the current concepts on the established as well as plausible biological mechanisms which are connecting periodontal disease to all these systemic disorders. So, and I hope you bear with me. So now, what is periodontal medicine? Now, we all know that the relationship of oral and overall health has been established a long time back. And in William Hunter, when he put forward the focal infection theory, he was a person who, actually, it was in 1891 when Miller had conceptualized the thing that the oral cavity, the disease is not specific to oral cavity itself, the periodontal disease. It has implications to other parts of the body also. And based on that, this focal infection theory was brought about by Hunter in 1900, and it encompassed that periodontal, endodontic, or any kind of dental infections arising from oral microbiome can lead to translocation of bacteria and bacterial metabolites throughout the body. And after this, there was a widespread of use of this concept, and for the next 30 years or so, there were treatment modalities based on this, using wide extraction of the tooth, to be more specific. But then the incidents.
Excuse me, ma'am.
Yeah.
Ma'am, can you please make it full screen?
Yeah, it is
Slide
full
share.
screen.
No,
It is
ma'am,
full
it is not showing.
full screen, huh? And for me,
Yes.
it
For
is.
you, it is showing.
Yeah.
Okay, ma'am, then we'll continue. Maybe it will change for us later.
No. Okay. Okay.
Yes.
Then let me do something for that. I don't know.
No, Arpita, the slide share in the right corner, down. The slide share.
Slide share. No,
Yeah.
for me, it is coming as full screen.
Okay. Then it's okay, you continue, because.
Yeah. Okay. Yeah. Or do you want me to change something?
No, we have the slide share option, right? Down. We are getting to see the entire presentation.
Okay.
Yeah, you have the slide share option, right? Slide share. Down.
In the share, I have. No, I didn't get that.
Percentage of your whatever view, you have a slide share option.
No.
Yeah, slideshow option, slideshow. Yeah, put the slideshow.
No. I cannot.
You're not able to do the slideshow.
No. Okay, just bear with me. I will get it solved. If it is possible.
Just that you need to click slideshow. That's it.
No, for me it is actually going to slideshow.
Okay.
For me, I mean, I can see only my slideshow.
We can see more all your slides and your notes and all. That's it.
Yeah. I know. 1 second. I'll see if I can do something about that. I don't know. Mom, zoom.
మ్యామ్ హలో మ్యామ్ జూమ్ కాల్లో స్లైడ్ షో పెట్టాలా మ్యామ్ నార్మల్ స్క్రీన్లో
Now it is full screen, ma'am. Now it's fine.
Okay. Am I audible now?
Yes, ma'am. Yes, ma'am.
I'm sorry for the disturbance. I am a little poor in all this. Okay.
It's
So
fine.
thank you. Okay. So I was going through the focal infection theory, and then in between 1940 and 1980s, there was a total rejection of this theory. And after the late 1980s, the periodontal literature started again to start this studies on this interrelationship again started worldwidely. And then in 1996, the World Workshop of Periodontics accepted the term periodontal medicine, and it was used to define how periodontal infections or inflammation may lead to an extraoral health. And in this super tree, which was given by Monsar, it was given in 2016. There were actually 57 associations of periodontal disease with other systemic diseases, and they were categorized into major associations in which there were more than 5 to 30 reported studies, minor, and there were less a number of less than 5 studies which were reported, and the intermediate in which there were around 10 to 15 studies reported of an established association between periodontal disease and systemic problems. So I will be also discussing them in that order. And while many of the common things are common mechanisms have been discussed in various interrelationships between periodontal disease and systemic disease. The ones which are most commonly discussed, I have tried to enumerate them. And the first one is the common genetic and acquired risk factors between any periodontal disease and systemic interrelationship. And these are basically observational, done by observational studies. And the second most common mechanism of interrelationship is a low-grade systemic inflammation, which is usually caused by hematogenous bacteria dissemination, or by a spillover of their inflammatory mediators to the bloodstream and then to the target organ. The periodontal bacteria on themselves also have a direct effect, and it is usually through hematogenous or transtracheal migration of either the periodontal pathogens or the periodontal pathogen mediated inflammatory mediators. And these are the concepts which usually were the earlier links which were established. In the last 20 years, the other two links which have been more widely researched are the immunometabolic alterations and the alterations in the bone marrow, which are resulting from a periodontal infection. So giving a little brief on the oral and hematogenous migration of the periodontal pathogens or their mediators, it is usually carried out because of the effect of these periodontal pathogens on the endothelial integrity, wherein gingipains have been shown to disintegrate the PCAM and other receptors which maintain the tight junction. And there also has been a hematogenous spread to the brain, which crossing the blood-brain barrier, as you see it in rheumatoid arthritis, or there is also the role of periodontal bacteria, which is seen in the hematogenous spread to the gut also. And these have been used to explain the interrelationship between periodontal disease and certain autoimmune disorders also. Now, periodontal bacteria per se also have the effect directly on the systemic organs. For example, the most commonly seen microorganisms is the effect of PG. I would like to mention here about PG, especially why it is being used, is because PG is known to somehow evade the host defense. With there are a lot of different ways which have been enumerated, and this is actually, this organism has been the mainstay of connection of direct effect of periodontal pathogens on the various systems. The other periodontal pathogens also have been mentioned. So we'll be discussing that when we go through the various systems. And the one of the major line of research nowadays has been the role of trained immunity and maladaptive inflammation in interrelationship between periodontal disease and systemic diseases. Immunity as such gives it prepares the host for defense against any infection, and it is usually done by either an adaptive or an innate immunity. And they say that the memory of the first infection or an inflammation is usually done by an adaptive immunity, but sometimes, especially in susceptible hosts, when after apart from the adaptive immunity, the innate immunity also brings out certain phenotypes of memory cells, which are known as trained immunogenic cells, and as compared to the adaptive immunity counterparts, these trained innate immunity cells, they usually do not have specificity. And that's why when there is a second attack of same injury or a different kind of an inflammation or injury, these trained immunological cells give a very exaggerated response, which not only caters to the defense against the infection, but also leads to self-destruction, which is most commonly seen in periodontal disease as well as the connecting systemic diseases. Now, the other effect which has been most commonly nowadays seen is, studied, is the effect on the bone marrow, or the alterations which happens in the bone marrow. Because if you know that these the memory cells of the T helper cells which are present in the bloodstream are usually of a very short lifespan. So how can you have such an exaggerated response even after the second phase of injury? And that is explained by the alterations in the bone marrow. That is, the alterations, the bacteremia can lead to either alterations in the osteoclastic mesenchymal cells population, or they can also have what is called a strain myeloporosis, where the bone marrow hemopoietic cells are being altered, because and the altered phenotypic expression cells, they lead to an exaggerated response and a connection between periodontal disease and the systemic diseases. Now, how these various kind of interrelationships are commonly studied are basically either by epidemiological studies, which can be cross-sectional or longitudinal, and they can study either a defined population or something like, for example, for genetic relationships, it can study a group of families or twin studies. The animal models which are most commonly used are mostly the ligature induced periodontitis, or gastric, the oral gavage, which has been used especially in cases of P. gingivalis, and also clinical studies which either enumerate the presence of the bacterial periopathogens in the systemic etiopathogenesis, or they enumerate the biomarkers, or they are interventional studies which will see the effect of periodontal treatment on systemic disease pathology or the treatment of medical or the medical treatment of systemic diseases, and study the effect on the periodontium, and this will indirectly support the role of or the correlationship between periodontitis and systemic diseases. So this is a general thing. Now, when we were going through the literature research, I found this very interesting article, which is a timeline of periodontal medicine in the past 100 years by Beck and the other stalwarts of periodontitis. And they have basically mentioned 29 landmark first of a kind studies through these 120 years of periodontal medicine in the three most prevalently associated periodontal comorbidities, that is cardiovascular disease, diabetes mellitus, and adverse pregnancy outcomes. And they have given a kind of consensus report saying that in all these three systemic problems, there is a positive association between poor periodontal status and cardiovascular and the comorbidities. But and these associations have been held up by systematic reviews. But the indirect effect of which we study through periodontal therapies manifestation on the systemic health is still conflicting and inconsistent. And they have also pointed out certain lessons which have to be learned from these past studies in periodontal medicine, which in some ways explain the discrepancies between the studies which have been conducted. And the main points they highlighted was that most of the studies had heterogeneity in the case definitions of periodontal disease, and the role of comorbid inflammatory conditions were not that properly answered. And the study populations were usually selected randomly because, for example, there are always haplotypes which are for example, in rheumatoid arthritis in Korean population, there's separate haplotype which is not seen in Caucasian population. So if you study the same haplotype in Caucasian populations, you might not see that kind of an association. So we have to select our study participants very carefully, who are matched genetically, geographically, socioeconomically, and disease-wise, as well as the periodontal intervention, when it is used as an indirect link, then the time and intensity of the periodontal instrumentation or the intervention should be properly taken care of. Now, coming on to the first interrelationship, that is periodontitis and cardiovascular disease. Beck's article has outlined 10 milestone studies which had occurred in the past 120 years or so. And the most commonly cited is the one which is given by Matela, in which there was an association of dental health and acute MI, even when all the other comorbid or the other risk factors were considered. Independent of that, there was an association established. So that was one of the first landmark studies to be mentioned. And the second one was that of Beck, in which the mechanism underlying periodontal disease and its relation to CVD was propagated. And then there are a lot of these studies which I think you all should mention when you're writing both these in the interrelationship between PD and CVD. And all these studies have shown that the first thing which really marks the cardiovascular disease is the formation of an atherosclerotic plaque. And periodontitis and ACVD or the atherosclerotic vascular disorders, which we call, they share the common risk factors, and they also the interrelationship is explained in terms of infection, inflammation, cytokine theory, that is the increased formation of inflammatory cytokines and decreased downregulation of the anti-inflammatory cytokines, and autoimmunizations, usually the role of heat shock proteins. And these are the basic mechanisms, possible biological mechanisms, which explain this interrelationship. And this is a little detailed view of the same thing. I have kept this so that it will be helpful for you to go and explain for your examinations, this flow chart. Then if you summarize the various pathways which have been discussed, then you can see that there is conventionally the increase in systemic mediators, then antibodies, dyslipidemia, lipid peroxidation and all. And the newer pathways which have been proposed are that of the virulence factors and the increased production of extracellular reactive oxygen species. Now, to prove or to disprove whether CVD and periodontitis are related, the Reyes et al. In 2013, they have put forward certain proofs which say that periodontal disease and CVD are they have a close interrelationship. And the first proof is that the periodontal bacteria has reached the vascular tissues. They have been found in the affected tissues. The third, that they also affect the targeted vascular tissues. And then in vitro, when these were used in vitro cultures, then invasion of the affected cell type was seen because of the periodontal bacterial infection. Then demonstration that periodontal bacteria can induce or promote atherosclerosis in our animal models have been established. There has been an in vitro and in vivo evidence that non-invasive mutants cause significantly, that is, they say that, for example, P. gingivalis resistant strains cell, if you use, and then you see a significantly reduced pathology, then it proves that if there is a proper P. gingivalis infection, then there will be an increased pathology seen in the particular cell type. So that kind of proof has also been established. Only the last one, that is periodontal isolates from human atheromers, only one study has reported it. So this is an area which is still to be evaluated and proved to say a definitive correlation between cardiovascular disease and periodontitis. And the other ACVD deformities like coronary disease and heart disease and stroke, they also have been implicated with the connection, that is through bacteriology, as well as that these patients show an increased in the periodontitis status and tooth loss. This is the most recent study by Zardavi et al., which has shown that tooth loss is also a risk factor for increased incidence of coronary heart disease. So what does all this information come down to is that there is a strong interrelationship between periodontal disease and coronary heart disease, but the magnitude with which they affect the progression of periodontal disease and the progression of the cardiovascular disease interrelationship is still not completely understood. And the implications of this knowledge have been summarized into guidelines for both the dentist as well as cardiologist, so that an integrated kind of treatment approach can be followed. So now coming on to the next interrelationship, that is diabetes mellitus and periodontal disease. And surprisingly, the first reported interrelationship study was actually an interventional study which was done in 1960, which showed that periodontal therapy can actually reduce insulin requirement. So it all started with an interventional studies, and there have been almost 12 landmark studies which Beck and all have enumerated. And recently, in the past 10 years, we can see that only two very important intervention studies have occurred, and they have shown the effect of non-surgical therapy on which does not show an improvement in the HB1AC levels. And the other studies showed a mixed response. So this area on the influence of periodontal treatment on diabetes is still an area which is being furtherly investigated. Now, the pathological mechanism which links periodontitis and diabetes mellitus is obviously based on the bacteremia or the hematogenous spread of microbial flora, the inflammatory burden, hyperglycemia, age and rage, as well as the effect on bone homeostasis. But the areas which are now being investigated more are the biological plausibility of an effect of treatment, as well as the effect of prediabetes on periodontitis. And if you see the two-way relationship, this is the only the systemic disease where all the proofs have stated that there is a two-way relationship. That is, periodontitis as a consequence of diabetes, it is explained by hyperglycemia, defective PNM and host response function, defective collagen synthesis, and which leads to rage and aggravated periodontal disease, as well as periodontitis as diabetes as a complication of periodontitis, in which the bacterial endotoxin, they increase the inflammatory cytokines, which leads to hyperlipidemia, destruction of the pancreatic cells, and increased insulin resistance, which in turn leads to diabetes. So what the current literature, the current concept of interrelationship between PD and diabetes mellitus states is that the link is intimate. There is a potential role of periodontitis in the development of incident diabetes, and cross-sectional studies have proven this in two-way relationships. 2/3 of the study have suggested that there is a positive role of periodontal therapy in HbA1c reduction, but there is an insufficient support, and these are the kind of studies which have to be further investigated. Now, even the Indian perspective of this has been developed with the joint there was a seminar which was done in NCR in 2019, and they have given out a set of guidelines which should be followed by dentistry as well as the general medicine people, which gives a combined combined guideline approach to solve both periodontitis and systemic problems. Next, we move on to periodontitis and obesity. Now, obesity is one of the metabolic syndrome disorders which is it's an alarming thing for the developing countries as well as the developed countries in the recent past years. And the signaling pathway which connect obesity to periodontitis is mainly based on the presence of acute phase hepatic response, which is seen because of the adipose cytokines, the alteration in the gut microbiome, as well as gut permeability, and the increased inflammatory response, which alters the oral microbiology, and also the direct pathways, which basically say that because of obesity, there is a change in the dietary choices which we make, and which, for example, the fast foods and a shift to a more soft kind of a diet, which, propagates the periodontal disease progression. Now, this two-way relationship between periodontitis and obesity. Now, how obesity affects periodontitis is mainly explained by inflammation, immunodeficiency, impairment in the microcirculation, as well as overgrowth of pathogens, dysbiosis of the intestinal microbiota, as well as dysfunction of the permeability. The other way around has been proven by, that is, the periodontitis, how it can lead to obesity. It is usually explained in the terms of dysfunctional, the increased food intakes, which is usually because of appetite hormones or ghrelins, which are seen to be increased in periodontitis. Then the role of periodontitis in maintaining a chronic inflammatory state. Then the role of tooth mobility and tooth loss in the masticatory performance and preference to a soft high caloric diet, which may in turn lead to obesity, and also the effect of periodontitis on the intestinal microbiota, what we call as the oral gut axis dysbiosis. So that also are some of the biological plausible mechanisms which explain the role of periodontitis to cause obesity. Now, as recently a lot of literature has concentrated on the triad of diabetes, obesity, and periodontitis, and these triad is basically explained by the common risk factors as well as the effect or the cyclic effect on reactive oxygen species and elevated cytokines, which have explained the bidirectional effect of each of the components of these triad. So in these terms, I would like to introduce the term which is most commonly used in nowadays, that is comorbidity, which as defined by Feinstein, he's the famous epidemiologist, is the portraying the inception of one or more additional disorders co-occurring with a primary disease. And if you see literature in the American Diabetes Association defined periodontitis as a complication of diabetes in 2008. But the recent publications mention diabetes as a comorbid condition. Most famously, periodontitis and diabetes are termed as comorbid old friends. So, and why this is given, this comorbidity is now gaining more acceptance is because it explains a lot. The joint risk as well as the causal association is all explained in this. And why we are talking about comorbidity is because the incidence or the prevalence as well as progression of periodontitis in comorbid conditions as opposed to a singular disease is actually doubled so the periodontal destruction becomes more. So that is the reason now periodontal interrelationships are more studied in terms of comorbidity. Two of the very important comorbid conditions are periodontitis and metabolic syndrome. Metabolic syndrome is usually, the criteria is if that any three satisfactory conditions, for example, increased abdominal circumference, low HDL cholesterol concentrations, elevated triglycerides, elevated blood pressure, elevated glucose levels, and nowadays pre-diabetes. Out of these 6 criteria, if any 3 are met, they come under the metabolic syndromes. And it has been shown that there is a 1.38 to 1.99 times increased odds ratio increase when there is an association between MES and periodontal disease. And metabolic syndrome increases the risk for periodontal disease by 38%. And this association is more stronger in women. And patients with metabolic syndrome have a 2.6 times more risk for developing periodontal disease. The other comorbid condition, which is most commonly nowadays being studied, is the cardiometabolic syndrome, which is a comorbidity relating cardiovascular diseases with the basic metabolic syndromes. And this is mainly explained in terms of the shared risk factors. And the odds ratio of people with Lang et al. In a recent study have shown that the odds ratio for cardiometabolic diseases increase as the severity of periodontitis increase. So these are the newer lines of study of interrelationship of periodontal disease with the systemic diseases. Now, coming on to the third most important interrelationship, that is periodontitis and pregnancy outcomes. It is a topic which is quite debatable in the past few years. Some studies proving, some studies disapproving. But if you see the timeline in the last 120 years, there have been 7 significant studies which have proven this association. The first study being done by Offenbacher, which associated preterm low birth weight and maternal periodontal disease. And as the literature increased, there were a lot of studies which were approving or disapproving these interrelationship. But we also have to think that the discrepancies which we see in this kind of associations is mainly because the sample sizes are a little smaller, and previously the methodology of the study was a little less specified or little less designed as compared to now. For example, example of this would be that if you see that in this 2006 study by Mikhailovich, it was found that periodontal treatment and risk for preterm birth had a null result. But when the same thing was again, the same study was again studied with a better methodology in 2008, it was seen that the results were positive. So this implies the role of a good, well-designed study when you are trying to study an association between periodontal disease and any other systemic disease. Now, the basic etiopathogenesis of periodontitis leading to a pregnancy outcome, adverse pregnancy outcome, is basically by the hematogenous spread or the transient bacteremia, which leads to a spread of the periodontal pathogens to the maternal fetal unit, and this creates an inflammatory response in this fetoplacental unit, and because of that there is trigger of parturition, and this can be explained by the direct and the indirect pathway, that is the direct role of oral bacteria through hematogenous spread going to the fetoplacental unit, or the indirect pathways in which periodontal disease mediated inflammatory mediators or periodontal microbial components, they can either cause an acute phase reaction through the maternal liver. And then these have led to the various adverse pregnancy outcomes like low birth weight, preeclampsia, or preterm birth weight. Now, so what do we conclude, or what is the current concept? It says that there are common risk factors between periodontal disease and adverse pregnancy outcomes, and there is a strong evidence that periodontal pathogens can translocate to the fetoplacental unit and instigate adverse pregnancy outcomes. But the premature and preterm low birth weight, the association is not well defined, and from Beck et al., as they have said, that despite the clear association between maternal periodontitis and preterm birth, low birth weight, preeclampsia, and preterm birth, large intervention studies are testing the effect of maternal periodontal therapy that is usually being carried out during the second trimester, have failed to document a decrease in the incidence of adverse pregnancy outcomes. Apart from the adverse pregnancy outcomes, there also have been a lot of studies on the effect of sex hormones on periodontal disease and vice versa. And certain newer lines of associations have come up, the predominant being the polycystic ovary syndrome, as well as the effect of periodontal disease on female infertility. They have not been directly, especially female infertility and periodontitis have not been directly associated through a common mechanism, but the effect has more been because of the presence of the other factors which lead to female infertility, and the effect of periodontitis on these factors such as obesity, on endometriosis, on hormone dysfunction through kidney diseases, and these functions may lead to female infertility. And the common proposed mechanisms, the mechanisms which have been proposed till now, are that there is a common chronic subclinical infection, hyperinsulinemia, abdominal HPO axis, and an increased inflammatory burden. But the research till now has stated that female infertility related conditions can only be considered as a modifiable risk factors towards periodontal disease, but current evidence does not support the role of periodontitis in female infertility related conditions. Now coming on to respiratory disease and periodontitis. Now respiratory disease here is after the three main stalwarts of association, the fourth most common or the most proven associations of periodontitis and systemic diseases. The lung is a unique microbiome because it is usually described as a transient but not resident, meaning that the microbiome in lungs are usually of a different origin and they come to commensal in the lung alveoli. And two theories which usually explain the lung microbiome is the topical continuity theory, which says that entry of bacteria into the lungs is usually through regular microaspirations from the oral microbiome, and the island biography theory, which is a little recent one, which says that the mainland is the oral microbiome, and this is the reservoir for the transfer of microbiomes to the various islands, for example, lung, gut, liver, etc. And chronic periodontitis and oral bacteria have been associated positively with the onset, progression, and exacerbation of pneumonia, influenza, as well as chronic obstructive pulmonary disorders. And this association, it was independent of all the other confounding factors. There was a moderate to strong association between periodontitis and respiratory disorders, and this link was more stronger in patients with aspiration and ventilator pneumonia. Now coming on to the various the plausible mechanism, the oral bacteria usually affect the association because it is seen that the viral or the bacterial etiology of lung disease is usually started with the adsorption of the virus or the bacteria onto the lung alveoli, and this is usually mediated by the two mediators, that is receptor for platelet activating factor, that is PARF, and periodontal pathogens have been shown to increase the presentation of these receptors both in the periodontium as well as in the lung alveoli, and this enhancement of receptor expression leads to an increased absorption of bacteria and virus in the lung, leading to the lower airway disease. The second possible mechanism is that the aspiration of oral bacteria may lead to an increase in the pro-inflammatory cytokine release, and it might exacerbate the lung inflammation. And the third possible mechanism which correlates these two diseases is the overproduction of mucin in the lung alveoli, which leads to destruction of the epithelial barrier, as well as there is dysbiosis of the lung microbiome, and these can in turn lead to lower respiratory disease in the incidence of the interrelationship of periodontitis to influenza is also one of the most established ones, and in which we see that the influenza virus, if it has to attach to the lower respiratory tract, there are two main proteins, that is the hemagglutinin and the neuraminidase, and periodontal pathogens like P. gingivalis have known to increase the receptors for both of this, and they have also been effective to in negating the effect of the anti-influenza drugs, and this is how periodontal bacteria has been correlated to the increase in incidence as well as progression of influenza. So what does the current concept says? That the presence of periodontal bacteria in the lower lung as respiratory disease is positive, and this also has been the major factor in the relationship between COVID-19 and periodontal disease. It is seen that the presence of pathological bacteria in the oral cavity of periodontal patients may result in their aspiration, which can expose periodontal patients to COVID-19 as well as increase the risk of complications. Now, the next, the proposed mechanism of interrelationship between COVID-19 and periodontitis is usually explained by either the presence of the receptors, that is the SARS-CoV-2 receptors, which is the ACE and the TMPRSS2 receptors, which are seen on the alveoli, as well as they have been independently shown to replicate in the epithelium as well as salivary glands, and their translocation to the alveoli has been seen. Also, the oral cavity has been shown to function as a reservoir for this SARS-CoV-2 bacteriology. So, this is actually this slide I've only put for the purpose of you to have a much detailed mechanism explanation of periodontal disease and coronavirus. Next, coming on to stress and periodontitis. Stress is basically organism's mechanism to fight out any kind of injury or fear. And in normal physiological conditions, stress leads to a behavior, to a coping mechanism against any kind of injury and inflammation. But chronic stress has been known to cause dysfunction or a disequilibrium, which can hamper the systemic health of a person. And stress and periodontal disease also have shown to have a two-way relationship, and this is mainly due to the effect on the hypothalamus pituitary axis, on the autonomous system, as well as the increased inflammatory burden. Along with this, mental illness and sleep disorders, which lead to, which is usually seen in chronic stress, can further exacerbate the interrelationship of stress and periodontal disease. Now, the main mechanism by which stress or depression can lead to periodontitis and peri-implantitis is explained by the neurobiological link, that is the effect on the HPA axis as well as on the autonomic system, as well as through neurobehavioral links, that is the modification or the changes which is seen in the hippocampal morphology, which may lead to behavioral changes, that is health related changes or health deteriorating behaviors, both of which can lead to an decrease in the oral hygiene maintenance and decrease in the compliance of patients and increased incidence of infection, leading to a periodontal immune microbiome unbalance, which leads to periodontitis. This is the most recent concept which relates chronic stress to periodontal disease. And along with this, dysbiosis itself has been shown that to propagate as well as trigger the stress and periodontal disease interrelationship. Next, coming on to rheumatoid arthritis and periodontitis. Rheumatoid arthritis is actually an autoimmune chronic inflammatory disease which affects multiple synovial membranes of the joints, and it is usually seen in the early decades, that is the third and the fourth decade. It's more predominant in females, and the etiology is exposure to genetic and environmental risk factors, as well as the autoimmune basis of rheumatoid arthritis is basically seen by the presence of anti-citrulline protein antibodies. Citrullinarization is actually a process in which the arginine component of the proteins are converted by a peptide DMT enzyme to citrulline, and because of this change, the host cell becomes an autoantigen. So, so that leads to an autoimmune response. And the genetic traits which are most commonly associated with rheumatoid arthritis are HLA class 2 and periodontitis and association and rheumatoid arthritis association has seen, I mean, there have been various studies establishing an odds ratio between 1.82 to 20.57 seen in some Spanish studies. The research till 2017, there were actually 152 studies which were done, and in a next single year, there were almost 52 studies which answered this association. So the plausible or the unifying hypothesis in which periodontal disease and rheumatoid arthritis are explained are divided into three. That is periodontitis, which precedes rheumatoid arthritis. And in this, periodontal inflammation has shown to lead to citrullinization and production of anti-citrulline antibodies, which lead to autoimmunity and rheumatoid arthritis. There are some common pathways like the effect on the osteoporogen expression, rankle, and TNF-alpha related apoptosis. And the most common or the most promising mechanism which explains is called the two-hit theory, in which there is a primary trigger which leads to formation of anti-citrulline peptidase antibodies present, and the second hit, which can be the periodontal disease, leads to an exacerbated inflammation, which in turn increases the severity of RA. Now, this the possible mechanism by which periodontal disease can aggravate RA is detailedly described by in this 2020 model, and this is kept basically for your reference. Now, so what do we, the current concept between RA and periodontal disease says is that there is an effect which was first proven in 1982. The effect of periodontal treatment on rheumatoid arthritis has shown improvement, but the effect of rheumatoid arthritis treatment on periodontal disease is still unclear. Periodontal disease and RA are interrelated. The association is interrelated only in a subset which is susceptible, but it is been postulated that all patients diagnosed with rheumatoid arthritis should undergo a periodontal assessment, as they have a higher risk of suffering from chronic periodontitis than the rest of the adult population. Now, coming on to osteoporosis, the three major mechanisms which interrelate this is the systemic to local bone resorptive disease, that is a weakened resistance and mechanical challenge from the occlusal forces can lead to an increased periodontal as well as osteoporotic incidence. Inflammation and bone hemostasis, that is the effect of increased levels of systemic pro-inflammatory cytokines, can have a detrimental effect and an osteoclastic effect on the alveolar bone as well as the other long bones. And the hormonal effect, that is the estrogen deficiency and the parathyroid hormone effect on bone homeostasis and inflammation. Now, coming on to Alzheimer's. Alzheimer's is a senile atropic disease, and it has the incidence of it has increased exponentially in the last decade or 2 decades, and that has been mainly because of the increase in the adult population, which requires need for attention in both medical and periodontal sense. And this Alzheimer's disease is usually divided into 3 stages, that is the preclinical Alzheimer's, the prodromal Alzheimer's, and Alzheimer's disease with dementia. And periodontal disease has been related to all 3 stages. And periodontal inflammation and bacterial burden has shown to have central effects in the brain through the tau phosphorylation and peripheral and increased in the permeability of the blood-brain barrier, as well as upregulating of active transport of AP. So this was the model which is being proposed, in which the effect of periodontal disease has been shown on both the peripheral and the central component of the disease. And P. gingivalis especially has been shown to induce Alzheimer's disease, mainly on it because of its ability to cross the blood-brain barrier and increase the amyloid B plaque formation, as well as phosphorylation of tau, and this leads to an increased severity of the Alzheimer's disease. Now, coming on to periodontitis and gut inflammation, the oral gut axis, which we know, the dysbiosis of this has been as an inflammatory burden has been now proven widely, and the association between periodontitis and gut inflammation is mainly explained by 2 pathways, that is the immunological pathway and the microbial pathway. The potential route of translocation of the oral dysbiotic pathogens into the gut is actually prevented by the first barrier of gut, that is the acidity. But P. gingivalis especially has shown that it can alleviate the effect of gut acidity and still propagate. So that has been one of the direct microbial pathway interrelating these 2 diseases. And the immunological pathway is basically by the effect of orally primed immune cells, like for example the orally primed leukocytes, which are seen in the lymphoid cells of the oral cavity. They especially the T helper 17, T helper regulator cells, and their effect on the gut inflammation. So the proposed mechanism for this is still under a lot of studies, and there has been no clear-cut associational concept still. It's all still under a lot of study. So the current concept which relates periodontitis to gut inflammation is at best at its association stage and not at any other level. Now, coming on to periodontitis and liver disease, the proposed mechanism which connects the 2 diseases is basically the effect of periodontal disease on the stimulation of the Kupffer cells, and the effect of bacterial lipopolysaccharides and peptidoglycans, which stimulate the innate as well as adaptive immunity, and also the effect of periodontal microbiome on the gut-liver axis malfunction. So these are the proposed mechanisms which relate, and an association has been seen. But out of the 4 liver diseases which have been named, that is the non-alcoholic fatty liver disease, liver cirrhosis, hepatocellular carcinoma, and liver transplantation, they all have shown patients have poorer status of periodontitis. In such patients do have, but the other way, that is the reverse association, that is the association of liver diseases, the periodontal disease causing liver diseases, has still not been established in this. Now, coming on to renal diseases, chronic kidney diseases, systemic inflammatory effects, they actually exacerbate the current already present disease, and localized damage to the periodontium along with the systemic burden can have a detrimental effect on the consumption as well as medication of chronic kidney disease patients, which affect their quality life, malnutrition, and predisposition to other diseases. And the flow chart here explains how chronic periodontitis can, if chronic kidney disease can exacerbate chronic periodontitis through the effect of toxemia, increased urea concentration, as well as increased salivary pH, which in turn affect the immune function, the inflammation, and the bacterial colonization. And this has been, this is the proposed model for the interrelationship between periodontitis and chronic kidney disease. But the last one which I would like to discuss today is the interrelationship of periodontitis and cancer. And inflammation and immune related mediators have been the hallmarks for both malignant transformation and periodontal disease. And the two most common periodontal pathogens which have been implicated to the connection between periodontitis and cancer has been P. gingivalis and F. nucleatum. P. gingivalis, because of the fact that it can evade host immune responses, and F. nucleatum especially seen in more cases of metastasis, and because it is been connected here because of its ability to co-populate and increase the infection burden. The shared risk factors between both the conditions is poor nutrition, poor oral hygiene, alcohol consumption, cigarette smoking, obesity, and their effects. And salivary biomarkers and chemokines have been promising tools for early detection of oral cancer. Now, the mechanisms which increase the cell proliferation, migration, survival, and angiogenesis, which lead to which lead to oral cancer, can be subdivided into 7 pathways. That is the role of oral microbiome, the role of inflammatory cells, cytokines, signaling pathways, autophagy, genetic alterations, upregulation of MRI, that is microscopic RNAs in periodontitis, and smoking and alcohol consumption. The periodontal disease, because of its dysbiosis, leads to 4 basic pathways. That is, first is the epithelial barrier dysfunction. It is shown that P. gingivalis have an effect on MMP9, which is actually a preserver of epithelial barrier, as well as on some other receptors which propagate epithelial barrier dysfunction. So P. gingivalis has been associated with epithelial barrier dysfunction. It has known to propagate chronic inflammation. It has been shown that because of its effect on the reactive oxygen species, it can lead to genetic damage as well as epigenetic modulation. And these are the mechanisms which positively associate periodontal disease and cancer. And this association is also been explained in terms of 2 pathways. That is the non-tumorigenic pathway, in which P. gingivalis affects the apoptosis, that is decreases the apoptosis and increases the oxidative stress, which in turn leads to increased progression as well as metastasis of the carcinoma. And the carcinogenic pathways, in which P. gingivalis has direct effect on the invasion, proliferation, as well as increased inflammation of the host cells, which in turn lead to the carcinogenic event. So with all this data, I'm where the future of periodontal medicine lie. Now, we all know that the association, the 57 associations which have been reported till now are still only part of the iceberg, and periodontal medicine will always be a significant topic for dental and craniofacial research, and it should continue to advance. The things which we have to take care to have an established association between periodontitis and other systemic disease mainly lies in the conduction as well as documentation of study methods. The epidemiological methods which study the association should usually be more conceptual and should include advanced methodological elements. The power of studies should be taken in care, and sufficient sample sizes should be considered. Usually, if you see that if the sample size is lower, then even if there is an association, the significance of the study decreases, and you usually tend to get non-significant results. And because most of these systemic diseases have an increased incidence, a larger sample size study is always more advocated. And future studies should also incorporate conceptualized theoretical models. For example, the Bradford-Hill criteria, which establishes the causal relationship between in epidemiological studies, and efforts should be made also to improvise these kind of criteria so that better understanding or a better conceptualized epidemiological model to study an association between two diseases can be done. And the other area of future of periodontal medicine is its use as a new diagnostic opportunities in which periodontal biomarkers can be used as an early indicators for more severe systemic problems. And the third line of research for periodontal medicine would be the inception of therapeutics, which is based on this knowledge of interrelationship. The example of would be the potential approaches to development of inflammatory bowel disease intervention by targeting the oral gut axis. Similarly, the other axes like the oral brain or the oral lung axis can be thoroughly understood. The associations understood, and targeted treatment approaches would be developed, which will help in a comprehensive management of patients who have a comorbidity of periodontitis and other systemic problems. So I would like to conclude with the statement that out of all the systemic associations with periodontitis, diabetes only agrees to the very strong two-way relationship, and the other systemic associations are still in their in some stage of emerging evidence. As aptly stated by Bradford-Hill, all scientific work is complete and liable to be upset or modified by advancing techniques, meaning that we as clinicians and researchers should design and should try to understand the association between periodontal disease and systemic disease in a more structured fashion, using certain templates like the disease association checklist, which will help assessment of current disease associations, and Bradford-Hill criteria and the Stowe statement, which will ensure stringent pathway to publication. And based on this, we have a clear understanding on the common pathology between periodontal disease and systemic disease, and this will help us to identify therapeutic targets in order to maximize treatment responses and give a more comprehensive management. these are the references which I have used, and a lot of these references are in only, I had only basically concentrated on the last 5 to 6 years of periodontal medicine. So most of these are very recent publications. And with this, I would like to thank the KSR Perio organization for giving me this opportunity, and especially to Esther for for considering me for this presentation. Thank you, Esther.
Thank you, ma'am. It was a very detailed presentation. I hope this will be very useful for our PGs. We'll wait for a few minutes for some questions, ma'am.
Yeah, sure.
Meanwhile, please accept our certificate from our
Thank
side,
you.
ma'am.
Thank you.
Thank you, ma'am. Yes. We'll wait for a couple of minutes, ma'am. If anybody has questions, they can share it in the chat group.
Yeah, actually, this presentation was mainly made with the view that this presentation will form a base point with which they can further investigate, and they can refer this for citations for their examinations or for the grand viva. So that's why since the topic was very big, I only concentrated on a very few things which were there. Periodontal medicine is quite a big field, so
Very true, ma'am. Very true.
putting
But
it into
I guess even
one
for our
word.
exam going PGs, if they go through this presentation, it'll be, they will have something to quote and all that during the exam.
And
Citations.
I have included all the citations so that they can easily go and they have the PubMed IDs also in that, so they can cross check it and have the original articles. I also have the hard copies, and believe me, they are really quite helpful in formulating all kinds of answers which we can get in periodontal medicine. So hope this is helpful.
Sure, ma'am. Sure, ma'am. It will be very useful for our PGs. Since there are no questions, thank you, ma'am. Now, I request Dr. Renuka Devi, professor from our department, to deliver the vote of thanks.
It deliver the vote of thanks in this webinar, Perio-Orb 2022. I thank our Vice Chairman, Mr. Srinivasan, and our energetic principal, Dr. Sharath Ashokan, for providing us an opportunity to conduct the webinar. I would like to express sincere gratitude to all the speakers, Dr. Arun sir, Dr. Anita ma'am, and Dr. Arpita ma'am, for sparing their invaluable time in sharing their knowledge and current insights about the most interesting topics of periodontology. I believe that this webinar session would create a great impact among the budding periodontists as the clinicians over here. I should thank our faculty members and my dear PG students for organizing this webinar successfully. I hope that you all had a great learning. We expect your presence in our future webinars as well. The feedback form link is shared in the chat box as well as in the WhatsApp group. Kindly fill it up. Thank you all once again.
Shall we end the meeting, ma'am? Thanks, everyone. Thank you.